Submit my side.
Thank you. Lovely. Okay, well, I think we will get underway. Good afternoon, everyone, and welcome to you. My name is Barb Milden. I'm the Vice President for Research and Professional Practice and Chief Nurse, and it is such a pleasure. Oh. We are live streaming. We'll see what we can do here. This could get boring really fast. Okay. Thank you, John. We are in such good hands with you. All right. Well, again, welcome. It is my pleasure to have all of you here with us tonight. I know we have an audience drawn from our community, from external to us, from inside, and our own staff members, and all other kinds of individuals. So a very warm welcome to all of you. So tonight, of course, you're here for the Open Minds Across Canada Mental Health Symposium event. And this initiative is led by Healthy Minds Canada, which is a national charitable organization that raises funds for mental health and addiction research and education. Since 1980, Healthy Minds Canada has funded close to 400 research projects in 42 teaching hospitals and universities across Canada. They are wanting to get the information that comes from this valuable research to the people who need it the most. And for that reason, Healthy Minds Canada hosts workshops and symposia across the country and has published the When Something's Wrong handbook series. These are valuable resources that help families, teachers, and employers manage mental health issues in their respective environments. Healthy Minds Canada is also in the process of developing an online interactive tool to help parents support their children who are facing mental health issues. More information on these services can be found in your packages. Also in your packages, you will find the agenda for tonight and biographies for each of our presenters. And to that end, we will keep our introduction of our speakers fairly brief. We are very pleased tonight to have a very talented roster of presenters, and I send my sincere thanks to each of them for the time and preparation they have put into being here tonight. Here at Ontario Shores, we are a public teaching hospital providing a range of specialized assessment and treatment services to those living with complex and serious mental illness. Exemplary patient care is delivered through safe and evidence-based approaches where successful outcomes are achieved using clinical practices that are drawn from the evidence and the latest advances in research. Our patients benefit from a recovery-oriented environment of care that is built on compassion, inspiration, and hope. Our organization is dedicated to education, research, and helping to reform the mental health system to improve access for all, to remove the stigma that often acts as such a barrier to those who need care. That leads us to the theme of our event this evening, From Hospital to Community, Transitions and Transformations. We know that one of the great challenges in healthcare is the transition of recovery, so people have seamless and supportive support as they move from hospital settings back into the community. Tonight, we will examine different aspects of this topic, from behavioral and vocational supports to assertive community treatment teams. We will provide both research and peer perspectives to this important topic. The objective for all of us this evening is to share important research findings, information, and resources on mental health and to improve the quality of life of the millions of people affected each year. Without this research, we would not have the findings and best practices that are the foundation of effective community services. I want to send a special thanks to the Canadian Institutes of Health Resources, CIHR, the Ontario Trillium Foundation, Sick Kids Foundation, and Michael Smith Foundation for Health Research for sponsoring Open Minds. And again, I want to extend a sincere thank you to everyone that supported the planning for this event and all our presenters. I will just now cover a few housekeeping items before we begin. The symposium will end at 8:30 tonight and not at 9 p.m., as was communicated in your confirmation emails. You'll all get to bed just a bit earlier. Washrooms are located to the left and right of our entrance doors. Following each presentation, we have left time for questions. We have a refreshment break scheduled for 6:30 p.m., and there is an emergency exit at the back of the lecture theater and two on either side of me at the front here. There are evaluation forms in your packages on the right-hand side, and if you do not have a package, we will distribute extra evaluation forms at the end of our session. Today, this event will be live streamed for future webcasting, so if you do not wish to be filmed, please seat towards the back of the lecture theater. And you will be able to view tonight's presentation from select sites across the country by visiting the Healthy Minds Canada website. Now it is my great pleasure to introduce to you our Executive Director for the Ontario Shores Foundation, which is also a co-sponsor of tonight's event. I'm very pleased that Mr. Neil Hannam has joined us, and he's only 3 weeks into his job. And we're giving him some big roles to play in such a short time. Mr. Hannam's 15-year career includes leadership roles within healthcare, community development, and the public sector at the regional, provincial, and international level. In 2010, he partnered with a fundraising council and a market research company to complete the first Canada-wide study on best practices regarding donor stewardship. He is currently establishing a national study on organizational sustainability and best practice during uncertain economic times. He is also very active in his community through several volunteer positions and mentorship roles. Please help me welcome Mr. Neil Hannam.
Thank you, Barb. And, as the fundraiser, I promise that I'll keep my remarks very brief, because really, you're here to see someone far more interesting than what I have to say. But I do want to draw your attention to a few things that we've been doing recently in the 3 weeks that I've been here. One of the things that is very important that we're working very hard on is mental health services for adolescents. This is a program that realizes the biggest barriers to the early identification of mental illness is the lack of awareness of the symptoms by youth parents, teachers, and even family doctors. And so even if you do suspect that you might have a mental illness in your family, one of the problems, of course, is where do you go to get help? And that seems to be a big problem for schools right now. And that's why Ontario Shores has created a program to reduce that. And we've been very happy to help fund it. So far, the program has been delivered in 87 schools in conjunction with 8 school boards and 2 independent schools. And as I understand it, over 600 teachers and educators have been trained to date. And in the curriculum obviously deals with how to recognize the symptoms of mental illness and where to go get help. And the Adolescent Mental Health Literacy Initiative is using the comprehensive curriculum previously developed by the leading psychiatrist, Dr. Stanley Kuchar. And last night we were at St. Clemens to announce more partnerships and show a documentary. And it was great as a parent of teenagers sitting in the audience listening to Stanley Kuchar talk about his own children and what they put him through. And I thought, oh, well, I feel a lot better. They're actually sort of fairly normal and not wanting to, stay in their room for 3 weeks at a time, which is obviously a very problematic symptom and one that would require more help. And I think the other parents at the event felt a great deal of comfort hearing his own struggles and what mental health really looks like. One brief thing as well, yesterday, and this is very much in conjunction of tonight's theme, we announced that Bell Canada has donated $150,000 to create the Bell Canada Youth Mental Health Clinic. The clinic will provide specialized treatment and intensive outreach for youth with complex mental health issues who may be reluctant to access services or require significant support for reintegration. And most significantly, this new clinic will provide clinical support to patients in a therapeutic and supportive setting. So if any of that is interesting to you as a donor and you'd like to find out more or support it in any way, you can go to our website, ontarioshores.ca, find the foundation, and then you can follow up with a gift to that. So thank you so much.
Thank you very much, Neil. And so it's an exciting time in our program as we turn our attention to our opening keynote address. And I'm very pleased to ask Mr. Ross Violo, a behavior therapist in the Duo Diagnosis Service and the professional practice leader for rehabilitation and behavior therapy here at Ontario Shores, to introduce our keynote speaker. Welcome, Ross.
Thanks, Barb. And thank you all for being here today. I see us here today to share in one of research and science's most important functions, helping people make more informed and better decisions. Our keynote speaker is a great example of the embodiment of this virtue, and I'd like to introduce him in a manner I think appropriate and fitting with the spirit of this conference. Dr. Feldman comes to us from the Center for Applied Disability Studies at Brock University, where he sits as the director and professor with the center. His department holds the first graduate level training program in behavior analysis in Ontario, and the impact of such a program can be seen in any service that supports the care of children and adults living with learning disabilities and experience behavioral and mental illness, as now service providers can demand better credentialed clinicians to deliver more effective and efficient services. Dr. Feldman is a clinical psychologist, a board-certified behavior analyst, a scientist practitioner, and a long-standing advocate for interprofessional biopsychosocial models of care. He's a well-established expert in behavior disorders, autism, developmental disabilities, child maltreatment, and parenting. He is a leading expert in parenting by persons with learning disabilities, having designed and validated a parent education program that's been emulated worldwide. Currently, he is a co-principal investigator with Francis Owen on the 3 Rs, which is a human rights training program for persons with intellectual disabilities. He's published extensively in peer-reviewed journals and books, and has given numerous addresses and workshops, and his interests and impact on people's understanding range in a broad range of topics, including early identification and intervention for children with or at risk of developmental, behavioral, emotional, psychiatric, and social problems, atypical development, including autism, developmental disabilities, developmental psychopathology, dual diagnosis, and behavioral genetics. Applying positive behavioral interventions for severe behavior disorders, and this is just a small sample of what you can find on Google, for example. Dr. Feldman, amongst behavior analysts, Dr. Feldman is in really high regard. He's well known for his kind interest and collaboration and supporting up-and-coming behavior analysts. And he serves as both a formal and informal mentor to many. So please join me in welcoming Dr. Feldman up here. Dr. Feldman.
Well, thank you, Ross, for that great introduction. And I'd like to thank Barb and Ontario Shores for inviting me to open up the presentations today. And also like to welcome people who are watching online, either now or in the future. I'm a little bit anxious. It's probably the first time I've been on the World Wide Web live, so I have to remember the audience is not just you, but also out there. So I should go back to the title. So this is the title of my presentation, the role of behavioral supports in transitioning individuals with intellectual disability from treatment bed to residential services. And of course, there is such a unit here, and I've had the opportunity to work directly and indirectly with Ontario Shores on this endeavor. So remember, I have a remote. So this is an outline. It's a lot for 40 minutes, but I'll try to cover most of it. I have to first start by acknowledging my partners and collaborators, in particular Lake Ridge Community Support Services, which supports behavioral programs here in this region, and in particular Karen Chartier, who is really a co-author on the study that I'll be talking about, and Jim Rayum is the executive director of Lake Ridge. I also like to thank Community Living Ajax Pickering Whitby for running the specialized treatment home that I'll be talking about, and the Central East Network for Specialized Care for setting up the treatment home and other services for people with intellectual disability and mental health issues. So just briefly, I'm talking about people with intellectual disabilities, and for a long time it was thought that they're not likely to have mental health issues, psychopathology, and so on. But in fact, it turns out they are more at risk for psychopathology than the general population. Some research shows that about 40% of people with intellectual disabilities also have mental health issues. And I'll be using the term dual diagnosis. I know that also has another meaning in psychiatry, but here I'm referring to people with intellectual disabilities and mental health problems. And my colleagues and I conducted a survey going back now about 15 years, where we surveyed 948 randomly selected individuals with intellectual disabilities across the age span and across residential settings. And when we sampled that group and interviewed their caregivers, we found that 66% were reported to have challenging behavior. So a majority of people who we've randomly chosen were reported to have challenging behavior. Interestingly, only 14% of those individuals had a formal psychiatric diagnosis. So the vast majority of people with intellectual disabilities, including children, adolescents, and adults, had challenging behavior, but not necessarily a psychiatric diagnosis. And the most common, is this on automatic? It's going, unless I'm accidentally pressing. Yeah, okay. Be careful. Yeah, I just did, yeah. And you can't see at the bottom, but the most frequent forms of challenging behavior were aggression towards others and self-injurious behaviors. In our survey, and the literature, for the most part, has found this order of prevalence of interventions for people with intellectual disabilities and challenging behavior. So pharmacological interventions are usually the most common form of intervention, then followed by behavioral, then crisis intervention, which really isn't a therapeutic intervention, but just dealing with the problem as it happens, counseling and psychotherapy. In the intellectual disability world, this usually means that the direct care professionals looking after the individuals, let's say in community group homes or in supported independent living programs, provide lay counseling and lay psychotherapy. Now, this is on automatic. I haven't touched it. Cognitive behavior therapy also is being used. Now, when we're looking at the research for people with intellectual disabilities, of that list, intellectual disabilities and challenging behavior, the only empirically supported methods are the behavioral methods. To understand why people with intellectual disabilities exhibit somewhat challenging behavior, we adopt a biopsychosocial model. And in your handout, you have an excellent article by several individuals, in particular Bill Gardner, who is a colleague of mine for many years, developed what they call the multimodal functional models. And so a lot of what I'm going to be talking about today, you will find in that article for those of you that have access to it. And in a biopsychosocial model, we are looking at the interaction of genetics and medical conditions, the person's history, as well as the current environment. And just to give you an example of how all these things can be linked, I'll talk about Stephen. Now, Stephen is a 2-year-old with autism spectrum disorder. He doesn't really speak much. He doesn't communicate. And one day, Stephen starts hitting his head real hard. He's hitting his head real hard. The parents, of course, don't know what to do. They're comforting him. They're trying to figure out, why is he hitting his head? Well, it turns out he has an ear infection. Okay? And with the ear infection, of course, he has a lot of pain, discomfort, and inflammation in his ear. And he has found out that if he hits his ear, it temporarily reduces that pain and pressure in his ear. So he continues to hit his ear because it's temporarily removing the pressure and pain. And I guess the pain caused by actually hitting his head is less than the pain relief he's getting from, or he gets more pain relief despite the fact that he's hitting his head. So what we have here is a situation where, because he has an ear infection, and because the ear infection causes pain, and because the hitting of the head around the ear temporarily reduces that pain, Stephen has learned to hit his head to reduce pain. Now, the ear infection, you can see here, does not directly cause the pain. It sets the conditions by which hitting his head would lead to pain reduction and lead to him learning that if I hit my head, it hurts less. Now, the parents realize he has an ear infection, take him to the physician. Physician treats the ear infection, no more ear infection. But Stephen continues to hit his head. Now wait a second. He learned to hit his head to reduce the pain. From the ear infection, there's no more pain. Why is he still hitting his head? I know what you're thinking. What did his parents do when he's hit? Those of you who are parents, what would you do if your 2-year-old started hitting his head? Oh, stop, it's okay. Don't hit your head. It's fine. In other words, Stephen, in addition to getting pain reduction when he hit his head, got a lot of parent attention. And it's possible that Stephen's continuing to hit his head, not for the pain reduction, which is no longer there, but for the extra attention he may get from his parents. So you can see here how we started with a medical condition, the ear infection. The ear infection created a condition by which self-injury was reinforced or strengthened through pain reduction, but is then maintained by parental attention. Now let's say you didn't know all this, and Stephen came, the parents brought Stephen to you when he's 20 years old, and you're interviewing the parents, and you said, well, when did the self-injury first start? Oh, you know, I think it started when he was about 2 years old, and he had pain in his ears, and he hasn't stopped since then. Well, there's nothing you can do about the source, the original source of the problem, which was the ear infection causing pain. Now you're dealing with a person who has learned to continue to hit his ear because some environmental contingencies are operating. In this case, attention. So when you look at certain conditions, perhaps things like schizophrenia, autism, traumatic brain injury, those conditions may, for a variety of medical and biological reasons, may predispose certain challenging behaviors. But whether those challenging behaviors maintain is if, for that person, those challenging behaviors continue to have a purpose. They work for the person in some way, and I'll describe different ways that can happen. So even though some of these challenging behaviors are very weird and bizarre and seemingly self-defeating, like severe headbanging, in fact, for the person, they may actually be adaptive because they get something the person wants or needs. And these things that the person is getting is usually something in the environment. Attention, a preferred item, or escape from something they don't want to do. And therefore, because these things are occurring in the environment, we can maybe do something about it. So now I'm going to talk a little bit about applied behavior analysis and the basic principles of applied behavior analysis that underlies most of the interventions we use, as well as the assessments we use to understand why the person is engaging in challenging behavior and what to do about it. So we have what's called a four-term contingency with behavior in the middle. We have setting events or a context in which the behavior occurs. We have immediate antecedents, or you may want to think of them as triggers of the behavior. We then have, of course, the behavior happens in the presence of those things. And then we have consequences of the behavior. And it's the consequences that strengthen or weaken behavior. So now we want to know, why is the person engaging in the challenging behavior? What is the motivation for the challenging behavior? So we can use terms like, what's the payoff for the behavior? What is the person trying to communicate? Or what we do in behavior analysis, we use the term function. What is the function of the behavior? And understanding the function of challenging behavior is the key to finding effective interventions. Once we can figure out why the person is doing what they're doing, what payoff are they getting, particularly if it's something we can change in the environment, and it usually is, then we can find an effective intervention. Oops. And just for those of you who are not familiar with these terms, very briefly describe when I talk about positive reinforcement and negative reinforcement and punishment, this is kind of what I mean. When the person exhibits behavior and something is added to the environment, parents pay attention when the child has hit his head, and that behavior increases over time. That's positive reinforcement. When something is removed from the environment and the behavior increases, that's an example of negative reinforcement. Now, there's a lot of confusion about the term negative reinforcement, and some people confuse it with punishment. But negative reinforcement, something is removed and behavior increases. So I'll give you a couple of everyday examples. You go out on a bright sunny day. You're hit with the glare of the sun in your eyes. You flip on your sunglasses. The glare goes away. You've removed something from your environment. You've removed the glare of the sun. What behavior has just been reinforced? Putting on your sunglasses, right? Are you more likely to put on your sunglasses the next time the sun hits you? Yes. That's an example of negative reinforcement. Okay? Another example from everyday life. It's now raining out. And you're walking down the street and you step in a puddle. And you get soakers. Very unpleasant feeling. The next time you walk down the street, you see the puddle, walk around the puddle. You don't get soakers. So you've avoided getting wet. It's another example of negative reinforcement. What behavior was negatively reinforced? walking around the puddle. So both positive and negative reinforcement result in behavior increasing over time. Or another way of saying it, it increases the likelihood that you will repeat that behavior again because it worked for you. It got you something you wanted, which is positive reinforcement, or it took away something you didn't like, which is negative reinforcement. On the other hand, if you do something and something happens and you are less likely to do that behavior, then that's called punishment. Now, punishment is not, as behavior analysts use it, is not the same as punishment as most people use it. You know, we say, I'm going to punish my child because he was bad. No, that's not what punishment means to behavior analysts. What punishment means to behavior analysts is the effect it has on behavior. It has to decrease the likelihood that behavior will occur again. So if a parent spanks her child for stealing, and the child no longer steals, then spanking, for better or worse, we may not like it, was an effective punisher for that child. I'm certainly not advocating corporal punishment, just as an example. But here's another example of punishment. You're a teacher in a classroom and you have a student in your class who's very shy. And she hardly ever raises her hand. So the behavior analyst has told you, you need to reinforce that behavior. So when she does raise her hand to answer a question, you should praise her, because then she'll increase her hand raising. So the teacher tries that. And let's say before the teacher started praising, the child was raising her hand maybe once or twice a day. Very little. After she started praising the child, oh, that's good, you raised your hand. I'm so glad you're contributing to our class discussion. The child never raised her hand again. Was that praise reinforcing to that child? No. The behavior didn't go up, it decreased. That praise was punishing for that child. Why? Don't know. Maybe because she didn't want to be singled out, who knows. But you can't prejudge what consequence will be a reinforcer or a punisher. And we have ways of determining that. I'll try to show you here. So, what are functions of challenging behavior? When we're talking about people with intellectual disabilities and challenging behavior. So, as I alluded to, attention can be reinforcing. So it's kind of like the person saying, I'm going to do this behavior, I'm going to hit myself, I'm going to hit you, I'm going to fall on the floor because I want your attention. Because when I do those things, guess what? You come and check me out. You know, you have to deal with me. Or it could be something tangible, something I want, some item, a food item. I want access to the computer. I want to sit in that chair. Something tangible. Or an activity. I want to go out. I want to watch TV. I want to watch my favorite show. I want access to the computer. So it's a person saying, this is going ahead of me, sorry, I want that, or I want to do that. Now, I'm not saying the person's actually saying these things, but sometimes it's easier to understand why a person would do such a bizarre behavior if we think about it in terms of a communication function. Negative reinforcement, we would look at avoidance. I don't want to do that. You know, so someone at a day program for a person with intellectual disabilities gives them some work to do, like sorting bolts and nuts, and they've done it 1,000 times before, and they're given that material and they throw it all on the floor. Hey, I avoided doing it, so I'm on the floor now. I don't have to do it. Or escape. They're working away, but they're done. They're done with it, so it gets thrown on the floor. They get to escape any further work. Now, maybe they can't really escape it. The work is given back to them, but they've delayed it by throwing it on the floor. And even that's better than having to work on it. There's also reinforcement that is not socially mediated, meaning a person doesn't deliver the consequence, either on purpose or without purpose. And this is called automatic reinforcement. And a lot of our behaviors that we do when we're alone are reinforced through automatic reinforcement. The result of the behavior, the consequence of the behavior, produces some sensory event or something that feels good, or, as in the case of Stephen, it reduces his pain. In other words, it changes some internal feeling, right? No person has delivered attention or removed things. It's all done through the way you feel. And that's called automatic reinforcement. So we take those basic principles of behavior analysis and we apply them to doing a comprehensive behavioral assessment to try to understand under what conditions behavior occurs and what is the function of the behavior. And that is what will lead us to effective environmental interventions. The first thing you have to do in understanding challenging behavior of an individual is define the behavior. You have to take whatever the person's feeling or thinking, which we have no access to, only the person has that access, and to define a behavior that we all can see and agree on. So, for example, if someone is physically aggressive, we can say, you know what his problem is? He's got an anger problem. But we can't see his anger. Anger is a feeling that he has. We can't see it. Now we can ask him, are you angry? And he can tell us. But what is the concern? What is the behavior of concern? It's when he hits us. And we can define that. He's hitting us with his hand, he's kicking us, he attempts to bite us, whatever. So we define the behavior. Then with the biopsychosocial model, we want to see, is there under any other biological or medical factors that are going on here that may have predisposed a person to behavior. And we do find that persons with intellectual disabilities and autism, that often if they're not feeling well, instead of just saying, oh, I feel horrible, which is what we would say, they exhibit some serious behaviors, aggression, self-injury, screaming, partly because maybe they don't understand why they feel the way they do. But nonetheless, these are setting events that can predispose the person to exhibit behaviors. Things like, certain genetic conditions like autism. We know there's certain core features of autism that make it difficult for the person to be in a social environment. Prader-Willi syndrome, where they seem to have an insatiable appetite. There are certainly people with acquired or traumatic brain injury are more prone to have short fuses and become irritable. So different syndromes may have different behavioral predispositions. Likewise, acute and chronic illnesses such as allergies, constipation, may also have a person more prone to exhibiting challenging behavior if they have an intellectual disability. Then, of course, if we see that the person has an underlying medical condition that may be predisposing, we of course try to treat that medical condition. Then we move into the functional behavior assessment, where we're trying to identify why is the person doing what he's doing, what are the environmental or internal consequences that may be maintaining these behaviors. And we look at setting events, antecedents, and consequences. And there's different ways that we can do that. Then we generate hypotheses about the possible functions of challenging behavior, and then develop an intervention. And I'll show you that in a moment. There are many ways of determining the function of behavior that have been developed. A common way is an informant questionnaire. So we ask a caregiver, or sometimes the person themselves, to answer some questions. So for example, does this behavior, let's say physical aggression, tend to occur when the person hasn't received much attention for a while? If caregivers rate that item highly, yeah, that happens a lot in this case. Then it may be that maybe attention is a function of this behavior. Or another question may say, does the aggression occur, is the person successful in getting something they want when they're physically aggressive? In other words, push you out of the way and I get to sit in your seat because I like that seat. If so, maybe the function is tangible. Is a person aggressive when we give him work to do or we ask him to do something? If that's rated highly, maybe there's an escape function. So we ask caregivers to fill out a variety of these items to try to pinpoint at least what they think may be the possible functions. We then would do a descriptive analysis, natural observations, using in something called the antecedent behavior consequence log, where we now, when the behavior occurs, we write down what happened just before the behavior, the antecedent, what happened just after the consequence. And if we get a number of different episodes recorded, we may be able to see that, oh, look, every time he hits himself, he gets attention. Maybe attention is a function in this case. Both informant questionnaires and descriptive analysis only gives us a guess as to what the function is. It does not confirm the function. There's only one way of confirming the function, and that's experimental functional analysis. Unfortunately, I don't have time to get into that, but basically what we do in experimental functional analysis is we purposely control the delivery of the consequence. And we run sessions where, for example, if the person is engaging in screaming, we will first test attention. Every time the person screams, we will give the person attention, and only when the person screams. And we do that for about 10 minutes and record the rate of behavior. Then we would run, let's say, an escape session. We give the person work that we know he doesn't like to do, and if he starts screaming, we make it clear, we take away the work for about 30 seconds. Then we give it back. And if we get high rates of behavior in the escape condition, then we can determine whether the functions escape. So that's a very, very brief description of experimental functional analysis, but it's the only way we can know for sure what the function of the behavior is. Positive behavior support is the service delivery method we use to use the principles of applied behavior analysis and biopsychosocial model to identify and implement treatments. And positive behavior support has three main components: prevention, increasing alternative behaviors, and decreasing the target behaviors. When we are dealing with a person with severe and frequent challenging behavior, the first thing we really need to do is calm things down, get things under control. Try to create an environment where the person is not motivated to exhibit the challenging behavior. In other words, prevent the behavior from occurring. And what we do, is something called the zero baseline. We try to remove all the triggers as best as possible. So, for example, if you have an individual living in a group home and every morning they wake them up at 7 a.m. to get ready to go to the day program, the van comes at 8:30, and every morning when they wake him up, he starts aggressing against whoever tried to wake him up, and he refuses to get out of bed, and it's a big struggle, and eventually they get him out of bed, and often he's late and misses the van, and they have to drive him. Well, a lot of staff are getting injured to get this guy to the day program. In a zero baseline, we would say, reconsider temporarily your priorities. Do you want to get him to the day program and get hurt? Or you just maybe just suspend him going to the day program? And of course, often the staff will say, well, we can't let him stay home. There's no staffing. Well, we got to talk to the management about this. But of course, we're not going to forever let him get away with whatever he wants to do. We are now going to implement interventions to teach him to get up in the morning, or to figure out why he doesn't want to get up in the morning. We can also alter setting events and antecedents. So if you have a person who's kind of sitting there all day, not getting any attention, and every time someone walks by him, he sticks his leg out and people go flying. Right? Well, and then people say, you shouldn't do that. You shouldn't stick your leg out. It's not nice. Don't do that. So he's sitting around all day. He's not getting any attention unless he sticks his leg out. People fall, he gets attention. So one thing we can do to alter that environment is just give him more attention. Just set up some kind of schedule where staff have to give him more attention. It's not contingent on appropriate behavior. You just, of course, you're not going to give it to him if he's tripping people at the time, but just enrich his environment. Make it more pleasant. Why would he trip someone for attention when he gets tons of attention? He doesn't need to trip anybody. Differential reinforcement to increase alternative behavior, and functional equivalence training. Now, this is where we are identifying the function of behavior, let's say the aggression or self-injury, and then we're going to figure out a behavior that will get him the same reinforcer. Often that behavior is some form of communication. We're going to teach him, instead of sticking your leg out to get attention, we're going to teach him to ask for attention. And when he asks for attention appropriately, we will give him attention. So he doesn't have to trip people, or hit his head, or aggress to get attention. If the person is verbal, of course, we will try to get him to use his words. If they're not verbal, and have low cognitive abilities, we will teach a very simple response. For example, raise your hand. If he raises his hand, oh, you want some attention? What do you want to do? You want to do something? Yeah, I'm here for you. So often the replacement skill is a form of communication that empowers the person to get the reinforcer, the same reinforcer he was getting through other means, mainly through aggression, self-injury, screaming, and so on. However, why would the person switch to an appropriate communication? Why wouldn't they continue just something that's worked for them? Aggression, self-injury, screaming, for example. Well, you've got to make that alternative behavior be more effective in earning reinforcement. So maybe he gets more reinforcement. Oh, 5 minutes. No way. Okay. It has to be more reliable. You have to make sure that in the beginning anyway, he gets that reinforcement every time. And it has to be efficient, something easy for him to do, like raising his hand. So here is some functional communication training that we teach people with intellectual disabilities. For attention, please come here. For tangibles, I want that. For escape, no more, break, stop. And again, they don't have to say these words. If they're nonverbal, we'll teach them simple responses, whatever works for that person. Okay, in the 5 minutes I have left, I'm going to show you how we apply these principles. The Central East Dual Diagnosis Treatment Home is in a rural setting in North Durham region. It's in a spacious home on I think about 10 acres of property, and it's run by the local Community Living Association. Behavior support provided by Lake Ridge Community Support Services. There's psychiatric and nursing support and social work support, I believe, also from Ontario Shores. And I have to put in a plug since I'm here. Great working relationship between Ontario Shores and this dual diagnosis treatment home. It's 5 beds, staffed 24/7, usually with 2 staff. 1 staff comes in the evening. There's a supervisor and an in-house behavioral technician. And since 2006, 16 clients have gone through or are currently residing in the treatment home, 10 of whom came from Ontario Shores, primarily the dual diagnosis unit. And 11 of those 16 have been discharged. In other words, there's 5 currently living there who, of course, we're getting ready for discharge. Here are some results on the first 7 clients for whom we have good follow-up data. This is the change from baseline in their target behaviors from the pre-admission, wherever they came from, to post-admission. Well, when they come from Ontario Shores dual diagnosis, we're looking at data from where they were in the community before they went into Ontario Shores. And you can see that the range of behavior change was approximately 30 to 90% across the first 7 clients. In terms of reduction in target behaviors, most of the individuals had self-injury, aggression, property destruction, screaming, elopement, like all the really severe, challenging behaviors. Some of the individuals had psychiatric diagnoses. Some had autism spectrum disorders. I'll just go for one case. That's Charles. That's not his real name. 21 years old, borderline intellectual disability, Asperger's syndrome, and obsessive compulsive disorder were the diagnoses that he had when he came to us. As I mentioned, target behaviors, aggression, self-injury, destruction, and yelling. When we did our descriptive analyses, it appeared that he would exhibit these behaviors when he wanted something right away, but he had to wait, or when he was denied something he wanted. Obviously, the function was access to tangibles. So Ontario Shores had done a good job stabilizing his medication, and where they remained stable during the time he was in the group home, I believe about 7 months. We did tolerance training to get him to wait for getting something he wanted. And very quickly what we did, we first did a baseline to see how long would he wait before he would exhibit a target behavior. And it was about a minute. If you didn't give him what he wanted in a minute, he was all over you trying to get it. So what we did is we started tolerance training. If he wanted something and he waited 20 seconds, we gave it to him. Before he had a chance to get revved up and exhibit any target behavior, and we praised him for remaining calm and waiting patiently for the item. And then we gradually increased the time. And that's what the tolerance training is. We also did some role-playing and video feedback training for improving his social skills, improving his social communication, to ask for things nicely, that went along with the tolerance training. And here are his results. We had 2 months of baseline while we did our assessment. Then we implemented the treatment, and you can see his behavior went down to 0 by the 8th month. Then we discharged him back to the family home with his parents. And these are data reported by the parents, and he also had respite workers into the home, and you can see the behaviors remain low. Some other results, police contact before to after discharge was from 4 to 0. No hospitalizations when he was returned home after discharge. The cost of property damage went way down, and he had no target behaviors when he was taken out into the community. And the parents reported a significant increase in their quality of life. They could take him out. They could have friends over and so on. Now, I'm going to end by giving some suggestions about how the hospital and the community can work together to support individuals like this, since the topic is discharge into the community. And obviously, the hospital has a very important role to play in stabilizing medications and finding out what are safe and effective medications for this individual, particularly if they have a psychiatric disorder. And then, of course, to conduct a diagnostic assessment, just what psychiatric disorders may this person have, but also to conduct a biopsychosocial assessment. This would be very, very helpful to the community to understand why the person's engaged in behavior and what are some of the genetic and medical predispositions. Now, it would be important to prepare for discharge, to go out and see where is a person going if it's known, and do an environmental scan. What's the environment like? Will the environment be able to support this person? Are there triggers here that we've learned when we did our biopsychosocial or multimodal functional assessment that still exist in this community environment that we may need to change? What are the staff competence? What more training do they need? And what management support will the staff get in implementing a positive behavior support plan? So that's what I mean by environmental scan. And then if you do test out interventions, or you're using interventions that could not be done in the community, such as mechanical restraint or seclusion rooms, and I know you're trying to cut back on that here in the hospital, but if it is being used, those things can't be used in the community. Try to fade them out. And if you can recommend and even test some effective interventions that could be done in the community, then you can go in with more confidence telling the caregivers who are taking over, listen, we're going to train you in something that worked for us and it's feasible for you to do here in this setting. That would be very helpful. And if you can then pass over your knowledge of the case to a local community behavior service, such as Lake Ridge Community Support for this region, then they can maintain the behavior support, training, and monitoring, and of course deal with any new problems that arise. Every region, a lot of communities have government-supported, government-funded behavior support services that could take over that role when the person is discharged. And of course, providing ongoing support to the community. One thing that Ontario Shores has been very good about, if in the treatment home someone went into crisis, we had arrangements where the person could go back for a short stay, sometimes just 48 hours, to get that person back into the hospital. Maybe the meds needed to be looked at, or something needed to be checked in the hospital, because they could not be handled in the community. So that is how we use my research and other people's research in behavior analysis and the biopsychosocial model to try to work with people with dual diagnosis and get them into the community, get them functioning in the community and improving their quality of life. So thank you very much.
Okay, so we did go over a little bit, but we still have a few minutes for questions. Does anyone have any questions they'd like to ask Dr. Feldman about his talk? Jennifer? I'm going to have to be running.
Thank you. Dr. Feldman, what are your thoughts on having, in thinking about the role of the hospital as far as discharge planning, meaningful activity for persons with dual diagnosis, such as employment and education, as part of their plan for successful reintegration back to the community?
I think that's a great idea. I think while the person is here, they certainly should be exposed to whatever opportunities that you can offer them in terms of education or recreation and vocational things, particularly if they're things that could be carried over into the community. I think one of the preventative strategies that is very effective for people with dual diagnosis is just giving them an enriched life. Often they're reacting to a state of deprivation where they don't get much in their lives. And it's kind of a vicious cycle, right? They don't get much in their life, so they start acting out, and then people avoid them. So they get even less support and attention. And you've got to break that cycle by trying to enrich their lives, finding out what do they like to do, and giving it to them. And often we find you can think of when you're in a fun, enjoyable situation, you're less irritable. And I think it's the same with them. Like, if they're getting a lot of fun activities, they have choices in what they like to do. You're listening to their preferences and giving it to them when you can. I think you're going to get less problem behavior for sure. And that should be something coordinated so when they move into the community, they're not going to lose out on that stuff. It may not be the same, but it'll be a community version of what you're able to offer them in here.
Thank you. One more question, please.
You talked just now about a life of deprivation, and I totally understand and get that. And my understanding from researching the incidence of physical and sexual assault, particularly on people with developmental delay and people with psychiatric diagnoses, is the highest groups of people in the world. In fact, in some countries, the minute a child is diagnosed, the parents are given tools as ways to discuss or to determine whether their child has been physically or sexually assaulted. So in your psychosocial, and it's very prevalent, so in your psychosocial assessment, do you actually address that high rate and question whether or not that could be a preceding factor?
Yeah, that's a good question. I did have that history, and that's exactly what we look for. Is there a history of abuse, neglect, or traumatic events that the person is not able to verbalize? And yes, we certainly look at that, and having been sexually or physically abused as a younger person, certainly a predisposing condition for all kinds of emotional and behavioral problems. And we do certainly look at that to the extent we can gather evidence. Yeah. Good question.
Do we have time for one more question? Thank you very much.
I just have a question regarding transition practices. So there are some great clinical and system level suggestions as far as an effective transition process. And I was just wondering what you found in your experience as beneficial practices on like the front line. And what I mean is typically you'll see staff suggest like visits to the home or having personal items present just to smooth out the transition. I'm just wondering if you found particular strategies more helpful than others.
I mean, I could give you a whole workshop on transition and discharge, but it's basically, yeah, you try to do everything that will make that transition as comfortable as possible. If in the hospital you've learned about his or her preferences, the kind of environment that has to be quiet, or they need certain kind of foods that they prefer. If all the, you've discovered that and working with them, obviously that needs to be communicated to the place that they're going to, and that can be used to develop a supportive, enriched environment and a preferred environment. and that's very important information. So above and beyond any specific support plans that involve, contingencies, the person does this, you do that, or teaching new adaptive behaviors, it's just what's the environment going to look like for this person. So yes, it's all great information that should be implemented when they're discharged. And also gradual discharge too is a really good point. Not just, many people with intellectual disabilities, particularly if they have autism, if you just transition them cold turkey, like, that in itself is a setting event, is a trigger. So even if you've built in really good things, but you do the transition too quickly, like one day you're here, next day you're there, in a new place I've never been to before, you're probably going to get an increase in challenging behaviors, and it'll be much more difficult to implement the interventions that you discovered worked in wherever they were coming from. Thank you, Ross. Thank you.
So I will add my thanks as well, Dr. Feldman. Your opening keynote for us has not only shared some of the science of helping people with developmental disabilities, but I think also given us some hope. So thank you so very much.
Thank you.
So in that folder.
How do I... John, how do I get it so it's from currency to slideshow?
Thank you, Dr. Feldman, for all your valuable insights. I think Jennifer's question in regards to vocational pursuits segues beautifully into our next panel discussion. My name is Erin Sawyer, and I'm a vocational counselor here at Ontario Shores, and I'll be your moderator for this panel. I'd like to take this opportunity to introduce our next speakers, who will be presenting on the importance of education and employment for both our inpatients and outpatients. Jennifer Gardner is our clinical manager here for vocational rehab and therapeutic recreation services at Ontario Shores. Diana Capone is joining us from CAMH in Toronto and is the Human Resources Employment Works Coordinator. And James Gasparini is our peer support specialist here at Ontario Shores. So if you could come to the front, and Jennifer will begin.
Good evening, everyone. It's a privilege and an honor to be here with my colleagues Diana and James to speak to you about transitioning patients back into the community through the provisions of employment and education services. I was kind of pleased that Dr. Feldman started off his talk by saying that he was a little bit nervous, so it kind of makes me feel a little bit good because I'm a bit nervous as well, and there's, always strength in numbers, so so bear with me. Okay. Today we're going to be talking about the evolution of vocational rehab services at Ontario Shores. We're going to discuss some key considerations of education and meaningful employment as an important component for bridging patients from the hospital to the community. We're going to provide some personal stories of success, courage, and discovery when employment and education is supported as an integral part of the recovery process. And we're going to also consider the need to look at different approaches for employment and education, alternate to the supported employment modalities. Since the early 1990s, there's been a significant amount of research on the delivery of vocational services for persons with mental illness, and traditional approaches such as simulated work environments were proven to only have limited effectiveness in helping people achieve their employment goals. The traditional model pre-2010 here at Ontario Shores was a sheltered workshop based on industrial training. It had limited consumer choice. The pay was an incentive allowance, so it was really sort of menial work for menial pay. In our current model, we support people's individual choice, group recovery-oriented services for both inpatients and outpatients. We're very much community-focused and interdisciplinary and holistic. Sorry, I'm not on? Okay. The approach is that we place people, then we train, okay? And there's no vocational assessment that is long-standing. The idea is that whatever the client is interested in, we will do our best to find a fit within the community to match their skills and interests. So research has shown about 70% of adults with serious mental illness desire to work. And employment has been identified as a key component for recovery for individuals with severe and persistent mental illness. Approximately 60% of consumers can be successful when working using supported employment services. Gary Bond, Deborah Becker, and Robert Drake have been instrumental in advancing the research in supported employment, and they have proven that supported employment services, particularly the individual placement and support model, is the best practice and the most effective way of helping people transition back to the community. So what is supported employment? It's an evidence-based practice approach to rehab for persons with mental illness. It emphasizes competitive employment in the community. The key considerations are job coaching, individual choice, paid employment, rapid placement, integrated services with the treatment team. Supported education is another service offering under the vocational rehab umbrella here at Ontario Shores. And I found this quote and I thought it was somewhat fitting. The only time my education was interrupted when I was in school. So many people with mental illness experience the onset of their symptoms in early adolescence, early adulthood. And this is the time when their education experience is at the forefront, and they have the serious break in education. And what happens is people experience a significant amount of loss and failure. Failure because they can't get through school. So supported education aims to facilitate the successful return to education for persons who have experienced a break in their education, an interruption due to their illness. Again, it's based on the principles of supported employment, similar, that it's person-centered learning based on individual needs and goals. Teaching staff are there to implement strategies and modifications and accommodations. It's peer supported. It provides assistance with academic upgrading, credit courses, English as a second language, and helping people connect to post-secondary education. In today's economy, gainful workforce participation is determined by one's education's level. So with the provision of supported education, we've seen a number of successes over the last 3 years. People who have obtained their high school diploma have moved on to college, have moved on to online university, what this does is it helps people prepare for employment once they are discharged from the hospital. There are a lot of stereotypes and stigma that surrounds working competitively when diagnosed with a mental illness. Some employers discriminate in their recruitment processes, or they fail to provide accommodation. And some people have difficulty advocating for themselves, or they worry they will not be successful due to their previous history or illness. The myths and realities you see here very much are what we hear as vocational rehab professionals. People with mental illness can't work competitively in the community. The reality is people with mental illness have many strengths and talents and abilities, and they can work in the community and be quite productive members of society. ODSP will be cut off if I work. How many of you have heard that? ODSP will be cut off if I work. Yeah, you know, and ODSP, there are systemic issues with ODSP, absolutely, and we all know it, that there's, you know, there are some issues with ODSP. However, ODSP does not cut off payments if a person chooses to work, but they do reduce the payments by 50%. It's not a perfect system, and it does provide some disincentives for our clients to choose work. However, there's other benefits such as increased self-esteem and confidence and you know, again, feeling connected to their community and feeling a sense of worth. That's what work provides. How many of you have ever gone to a social event? Hands up if you've gone to a social event. Yeah? Okay. So you're at the social event and you do your exchange. Hello, how are you? My name is. It's very nice to meet you. How long is it before you say, and what do you do for a living? For our clients, that statement can cause a lot of anxiety, a lot of fear, because they're feeling hopeless that I don't do anything actually. You know, so competitive employment, meaningful employment is really important to help reestablish that sense of identity. We are identified by what it is we do in society. A lot of times. I mean, it's not, that's one of the roles, right? And one of the values. So just some numbers. Prior to 2010, sorry, that black thing is blocking the numbers. But prior to 2010, we had very low community involvement with our vocational program. We had, you know, not a lot of people working competitively. In today's current model, we have over 35 people who are working competitively in the community right now. And we have over 80 people participating in our education support program. We have about 70 people participating in other vocational training as well, including training in-house here, which is in the gift shop or Good Luck shop, participating in the canteen. So our numbers have increased in this new model, and it has been quite successful. I want to share a story with you. This is Bob's story. And Bob is a 56-year-old male with schizophrenia and a brain injury. He's he is in supported housing, and he became involved in Ontario Shores many years ago when we had a program called the Brock Stop, and then he moved on to our workshop, our vocational workshop called Challenging Directions. During his years at CDE, Bob gained many employability skills, and he started to become involved in some individual work placements at Tim Hortons for about 2 years while he was still attending the workshop 4 days a week. After participating in the workshop for about 20 years, Bob chose the supported employment program, and with the assistance of our support staff, he was able to secure employment at a local grocery store in Port Perry. He's been employed there since 2010. The IPS model has worked for Bob as he's doing a job that he chose. He has a multidisciplinary team for support, and he earns a competitive wage. Bob has been a past nominee for the Durham Region Employment Network, DREN, the Employability Awards, and he is an inspiration to his peers. He's confident, independent, and proud of his accomplishments. This is Terry's story. Terry is a 53-year-old male diagnosed with schizophrenia who had been an inpatient at Ontario Shores for several years. He had a long-standing record of involvement with vocational services dating back to his regular attendance with Challenging Directions. During the transition of CDE, Terry opted to engage in adult educational upgrading. He's maintained regular attendance at our OSEP program for the past 2 years. He's completed 2 high school credits, and he's midway through his 3rd. He's participated in an employment readiness scale, which helped him identify some employment goals, and his most recent employment goal is to become a DZ truck driver. Ontario Shores employment program continues to support Terry in his post-secondary interests, and his confidence and faith in his abilities to be productive, contributing member to his community has been recovered. Terry's very hopeful for his future. So I'm going to pass along the stage to my colleague Diana Capone from CAMH. Are you introducing Diana? Or?
So Diana comes to us from CAMH, and part of her role is actually advocating for clients with mental health challenges and getting them hired at CAMH. So she's going to explain the successes and some of the challenges with that program, and also offer some friendly advice for our institution here. So thank you, Diana, for joining us. She came all the way from Toronto on the GO train, and she got here nice and safe, so thank you.
Thanks, Erin. I don't know where to put this. I'm assuming it's a mic, so I love your shoes, by the way. They're great.
Oh, John always has cool shoes.
Thank you. Hi, everyone. Thanks so much for inviting me here tonight. I'm very excited to be here. Although I work in Metro Toronto, I do meet with a lot of folks from the Whitby area, and it's always good to collaborate with others who are striving to achieve higher, or trying to reduce the high rate of unemployment faced by people with mental health diagnoses. So I'm a psychiatric survivor. I call myself a crazy person, and I can do that because that's my self-definition. I would get offended if someone who wasn't called me that. I was last hospitalized about 30 years ago at the old Queen Street Mental Health Center. Does anyone here remember the old? Yeah. They changed the address from 999 to 1001. And we have a lovely redeveloped site right now that is so integrated with the community. The whole landscape there has changed. If you have any opportunity to go by and take a look at it, you'll be awestruck. So I, since my discharge from the old, then it was the Queen Street Mental Health Center, it was a tremendously upsetting, traumatic experience for me. Where I was housed afterward was equally as traumatic. I ended up in an infamous rooming and boarding home, and made my mind up there that I wasn't going to live my life with a psychiatric label, that I was going to move on. Managed to go to college, had some really good breaks with employment opportunities. I founded and led the Ontario Council of Alternative Businesses, which developed a number of alternative businesses across Ontario that were managed and staffed entirely by other crazy people. I think we showed the world that people with mental health issues can have success. They do have skills. They can be relied upon. And we delivered great services, and those businesses are still largely functioning today. About 10 years ago, I was hired at the Center for Addiction and Mental Health to lead an HR initiative, a human resources initiative, whereby they were looking for someone who could recruit and help CAMH retain people with mental health and addiction challenges into the CAMH workforce. And so research has told me that in Canada, CAMH is the only employer that has a dedicated resource in HR looking to recruit people with mental health and addiction challenges. And of that, I'm extremely proud. You will find in many corporations, they'll have diversity departments, they'll have accessibility units, and even within those two fields, you'll be hard-pressed to find anyone recruiting people with mental health and addiction challenges. It's just not there. Even at CAMH, which is a lead hospital in Toronto, if not the province, around diversity, diversity never dealt with mental health. Hard to imagine, eh? You work in a mental health facility and you don't give any attention to people with mental health and addiction challenges. Not all that unusual, but I was initially struck by that. So my role was to help CAMH create a system whereby we could work with people, have them hired, not by creating positions specifically for people with mental health and addiction challenges. My first few years, many of the staff at CAMH told me about housekeeping opportunities. And, you know, housekeeping, there's nothing wrong working in housekeeping, but not everybody wants to do housekeeping work. I know certainly for myself, I couldn't stand doing housekeeping work. So I think CAMH has turned around in the past few years in that regard. We now have, through Employment Works, we have 320 people we've been able to offer employment to at CAMH. And that includes management positions as well, professional social workers, research docs, you name it. Mental illness does not discriminate. Mental illness hits every class, every culture in our society. People who end up in hospital and stay in hospital long term have the most disadvantage, and they have the most barriers to overcome, especially when transitioning to community and trying to have access to what I call full citizenship rights in this country, which includes housing and it includes a job. Everybody needs a job to feel productive, to feel that they're contributing to their society, to their community. When you're not doing that, even if you don't have a mental health issue, your mental health is going to be impacted. And we know that. We know that people who retire go through very difficult times because all of a sudden, where they used to spend the bulk of their hours, they have nothing to do if they haven't planned for retirement. We know that youth who are unemployed leads to gang violence, leads to educational dropouts, leads to poverty. But we know this, and yet very little has effectively been done around people with mental health and addiction challenges. And I could spend days telling you stories of people who have been professionals in their career, whatever they are, whatever that career was, who when they experienced a mental health issue and came out at work about this issue, or it was discovered, the horrific discriminatory behavior that resulted in them having to leave the workplace. Horrible stuff that's going on and still going on today, and from time to time even at CAMH. So as proud as I am about the initiative at CAMH, we still have a whole lot of work to do to erase some of the myths that have already been spoken about. In HR, they have this term called frequent flyer. So that's a term that says that supposes that people with mental health and addiction challenges will be away from work more often than people who have not. And in fact, research proves that's absolutely not the case. And that people who are so-called normal are much more likely to use their sick time and to be on leaves of absence than people with mental health and addiction challenges, largely because we're so appreciative to have the job, I would say. So we have this beautiful initiative at CAMH. We've hired about 320 people into our workforce. We do have peer support. That's the only designated position we have right now is peer support workers. We have 14 peer support workers at CAMH in a variety of our programs. And daily, the managers of those programs, the nurses in those programs, are seeing the impact of having peers on the inpatient units. They're also seeing the impact of having peers in our satellite clinics. And this is something clients have been asking for decades, and finally they're beginning to get it. And that's, I believe, the more of us working in the hospital, the more services will improve at the hospital, because we have high expectations of one another. That's why peer support works. That's how the businesses worked, because of peer support and peer training. We'll call each other on stuff, and we'll treat people like adults, right? In my present job, what I found is with those 320 people, the culture at CAMH is shifting. I attend every new employee orientation session, which is a legislated orientation. The poor clinical staff have to go through 4 days. The non-clinical staff go for 2 days. I go on day one, and I talk about the Employment Works Initiative. I talk about the rate of unemployment. Does anyone here know the rate of unemployment amongst people with mental health and addiction challenges? It's 86%. So I ask you to think in your geographic community, think of 2 blocks in each direction and a rate of unemployment at 86%. What do you think you'd see? Despair. Pardon? Despair. But how would that show itself? Come on, folks. 86% unemployment. Crime. Substance use. Violence. Domestic violence. Sole support parenting. Vandalism. Robberies. Right? If you're familiar, the United Way had this poverty by postal code initiative several years ago, where they identified significant parts of the city of Toronto where there was an increase in youth violence. So the municipal government, the provincial government, and the feds swooped into communities and offered youth living in those communities education. The colleges were there. It was very rapidly done. And these kids were taught job skills that they would get like double the minimum wage once they graduated. Many of the areas that they studied, there was a real demand for the workers. And so before they even graduated, they had job offers. And this was such an instant success. But because people with mental health and addiction issues don't live in one geographic area, we haven't been able to benefit from that. And I really wonder, would the feds have jumped in and the municipality if it was for us? They say today the rate of people experiencing mental health and addictions is 1 out of 4, I believe, in Ontario, and 1 out of 5 nationally. So that would mean in this room, maybe 10 people in this room, if not more, are presently struggling with mental health and addiction challenges. Where I work, we have 2,900 employees. So do the math on that. So a significant amount of people get hired at CAMH without going through Employment Works, are working at CAMH because it's very personal and meaningful to them, but don't feel safe enough to disclose that. And there's something wrong with that picture. So I would like to continue to hire more folks and do more talks. After every staff orientation, by the way, I get a phone call. We have an employee affinity group at CAMH. We're called the Unusual Suspects, and we meet regularly from all disciplines and all areas of the hospital, always over food because that's so much fun. And we get to know one another. And that's like a retention initiative, a way to support one another on the job. So it's interesting that out of a group of 40 or 50 new people you might have every month, there's always one or two that call me after, and I think they're very brave to do that, considering they're a brand new employee on probation. I went through Ontario Shores today. I hadn't been here for a few years, and it was interesting to see the cafe. It was interesting to see the gift shop. Interesting to see, and I'm a guilty one, there's people smoking at all of your entrances. And at CAMH, one of the things I've benefited from is that when CAMH has like a CAMH-wide problem, so not belonging to one particular unit or program, they'll often ask my opinion on their approach. So we went smoke-free a few years ago at CAMH, and CAMH's initial plan was to use security services to get people to comply with the smoking areas where they were allowed to smoke. And they asked me, what will the community think of this? We have people at CAMH who've been there for 20, 25 years. I was very clear this would not earn them any brownie points whatsoever. Both family members, clients, and staff, I would hope, would think this was a really heavy-handed approach and not appropriate for our security. I suggested the development of positions, and we called them the Clean Air Ambassadors, who would tour the CAMH sites on a regular basis and gently remind people of where it was they could smoke without the pointed fingers and without the judgment, right? They actually agreed. So I had 8 people working for 2 years at about $23 an hour, doing this work, getting recent employment history on their resume. I purposely hired all smokers, knowing that they would be more empathetic. That's probably illegal to do, but I did. And it worked so well that after the 2-year period, when we reopened, we had our official reopening at the Queen Street site, that we realized that we didn't have a very welcoming culture at CAMH. That you could walk into the Ming building and no one would smile, say hello, goodbye, nothing. They wouldn't acknowledge you. Very disrespectful, I would suggest. So we thought, let's take the Clean Air Ambassadors, turn them into a community ambassador, because in fact that's what they were doing in their past positions. And now they greet people. They do way more than the Walmart greeters, but they greet people, they remind people where it is they can smoke. If people are lost, and today the staff are lost, clients are lost, everyone's lost because it's a whole new site. In the summer, we had people, because of medications and because of illness, who would be lying in the sun in 40-degree heat. They'd have conversations and very gently and nicely move them to a shady area. A different approach from security, right? So now today we have 7 unionized positions. These are new job classifications at CAMH, referred to as, I got the 1 minute mark, but I could have one more, you said, a minute or more over. Okay, so we now have a brand new classification at CAMH, and the numbers have grown since that began. So that's been a good way for me to also develop some positions. But all of this came from up high. I had a VP of HR, and I had a VP of Community Relations and Communications at CAMH who really wanted to see the Employment Works initiative get off the ground and work. And without those 2 leaders in my arms, I wouldn't have been able to make a lot of the successes, or we wouldn't have at CAMH that we presently have. And I would suggest here at Ontario Shores, you have a cafeteria that's an internal cafeteria with internal employees. Why aren't you hiring your folks to get some training and work in there? Why aren't you working with the union to make that happen? I have a protocol with OPSU at CAMH. They've given me everything I wanted at CAMH. They have a social justice arm that will work with you. They could use the brownie points too. So here you have you can walk the talk, and that's what we say at CAMH, walk the talk. You have people doing unpaid labor. You know, I think placement is great, but over the long term, unpaid labor is not good for self-esteem. And anyone who's been in the system Oh my God, it's so hard to have self-esteem in the system. So any way we can build that for people so that they can market themselves out there, that would be wonderful. And in terms of vocational services, I've already warned you. I think it's really hard to help people build their self-esteem and to market themselves if they have no successes to rely on, or if they're deemed a patient, right? A patient implies you're sick, you need help. I haven't had very good working relationships with the vocational services at CAMH. They operate on a clinical basis. My successes with survivors from all walks of life have been provided in a non-clinical, very business, HR-related way. People compete for jobs, and I help them to compete. So I hope this is something that Ontario Shores will look at. There's a really exciting time in terms of educational opportunities. We have augmented education. We have the participation of community colleges. Universities are experiencing very high disturbing rates of mental poor health among its student bodies. So it's the perfect time to begin to partner and to be able to walk the talk. Thank you very much. Thanks.
Thank you, Diana. I've had the pleasure of knowing Diana now for approximately about 6 years. She's a firm supporter of the augmented education programs at George Brown College, which I used to work for. One thing I love about her is she's not afraid to put herself out here. In our initial planning meetings, she was dialed in via teleconference. We were talking about getting the numbers up and how we're going to market. First question that came out of Diana's mouth was, how are we going to get clients involved? So I think that speaks a lot about her passion and her lived experience in the system. So thank you so much for Diana for coming and sharing successes of CAMH and how we can move forward as an institution. Our next speaker here is James Gasparini. Again, we've leaned on him in our vocational services department for his lived experience when maybe we don't have the answers or we think that our clients could benefit from his lived experience. He's fairly new to the hospital here, and they've hired him back, which is excellent. He's going to speak a little bit about his lived experience as a consumer survivor, as well as his role as a peer support specialist here at the hospital. So thank you, James.
Great. Thank you very much, Erin, and thank you, Diana and Jennifer. And just following suit with what Jennifer was saying, I too am a little nervous as well. But good afternoon, everyone. My name is James Gasparini, and I'm a peer support specialist here at Ontario Shores. I'm just looking for the... I knew I was missing something. Wonderful. Once again, sorry for the interruption. For those of you who are not familiar with the role, peer support specialists are consumer survivors who have experienced and recovered from a mental illness, allowing us to better understand and relate to others facing similar challenges. We are living proof that people can and do recover from mental health issues. Our unique understanding of mental health allows us to draw on our own experiences in order to provide support, encouragement, and tangible hope for those also on the road to recovery. Peers assist peers by actively listening and engaging, by mentoring, by sharing, and by empowering. My education, both formal and informal, my transformation, and the knowledge and wisdom I have gained through experiences and sufferings has illuminated my path, my place, my purpose. I would like to share some personal events in order to give you a glimpse into the life of a consumer survivor, and please keep in mind this is just one story amongst the many here. I'd like to begin this account with a brief mention of the time and place of my birth. Windsor, Ontario, where I was born and raised for a time, was a city that I recall my father once saying, if you have only 1 year to live, spend it in Windsor, it'll seem like 20. It was in the summer of the psychedelic, hippy-dippy mid-1960s, during an era of crisis and change, flower power, Vietnam, you name it, it was happening. From what I've read and been told, society was unraveling at the seams. But for a 4-year-old, life couldn't have been sweeter. We lived on a quiet street nestled in a bedroom community. My early years were happy ones. Playing outdoors, car rides with family, and trips to the beach were commonplace. My mother and father seemed to have a great relationship and were very loving parents. My sister, who was a year older, was tolerable. It was the summer of '71 when I was 5 that my father did not return home from work. My parents had separated and ultimately divorced soon thereafter. During the next 5 years, my mother and sister and I would move a total of 13 times and struggle both emotionally and financially. Attending numerous schools during this time meant I was the target of constant bullying. Back in those days, fighting in the schoolyard was commonplace and an accepted norm by school staff. Sports became my escape and allowed me to calm my troubled mind and soul. I voraciously participated in many. Hockey, basketball, volleyball, tennis, and track provided me with a much-needed outlet. During my participation in these activities, all of my problems seemed to vanish. At 13, I first began to experience insomnia, racing thoughts, depression, and paranoia. Life was becoming a difficult stream to navigate. My symptoms lasted days, weeks, and sometimes months without reprieve. My family doctor at the time believed this was nothing more than a coming of age, as I did not completely disclose the range of emotions and thoughts that were with me on a daily basis. I had an innate fear that my secret, if spoken, would result in isolation from my family, friends, and self. I did not want to be considered different. Different in my teens would mean outcast. I met a girl in grade 11. Her name was Debbie. She was a student at another high school, and we soon started dating. For the first time in many years, I felt grounded. She did not mind my boundless energy, racing thoughts, and unique perspective, as she put it. Now, I do not know if my symptoms disappeared during this time, but I can say that Debbie helped normalize my state of being for the next few years. Between my relationship with Debbie and my participation in sports, I felt fulfilled. The only setback occurred during my final year of high school. I had been training for a track and field event when I seriously injured my knee. Surgery was required, and I would have the assistance of a cane for the next 18 months. On May 25, 1985, 2 weeks before graduation, I received a phone call at 7:30 a.m. It was a Saturday. No one had ever called that early. Debbie had been killed in a car accident, and I would later learn that the driver of the vehicle she was traveling in was intoxicated. He survived, sustaining only minor cuts and bruises, and that's how it usually goes. Depression, drugs, and alcohol consumed me for the next year, and I did not want to face the hard reality that was my life. Paranoia, suicidal thoughts, and reckless behavior guided me down a very troubled road. After almost a year to the day of Debbie's passing, after a night of drinking and drugs, I woke up in downtown Toronto at a friend's house, very sober, very alive, very different, manic. I can still recall vividly that I made my way home that day and was grinning ear to ear when my mother and sister greeted me at the door. My sadness and self-pity were no longer present in my soul. My racing thoughts and ideas felt streamlined, energized, and powerful. I felt an interconnection with everything. I had made peace with the world and the universe around me. The hate and pain I had been carrying for years, for my father leaving us, for the bullying I had endured in my childhood, and for the drunk driver the vehicle Debbie had been in, was suddenly gone. It was a strange, glorious feeling. No pain, no stress, no fear, just love. My mother and sister could not comprehend my new state of being, but felt happy to see the peace I had found. I started writing down ideas and designing numerous products. My energy and thoughts were endless. Working out during the day to strengthen my atrophied leg, I developed a workout regimen that would turn around my doomed diagnosis. Despite the doctors telling me that I would not be able to participate in sports again, I was soon walking and jogging without the assistance of my cane. In 6 months, my knee was back to 100%, and I began playing tennis again, training up to 8 hours a day. After my day of training, I had time to eat and then would race off to my cousin's nightclub, working as a waiter and bartender. I would arrive home at about 2 a.m. and would continue to work on my ideas, surviving on only a few hours sleep per night, and this was my schedule for the next 2 years. In this time period, I applied to a number of universities in the United States in hopes of attaining an athletic scholarship. I formed a business partnership with my dentist, Dr. Alan H. Simon, and created dental instruments designs for the consumer marketplace. I composed and introduced a motor vehicle safety device to James White, head of crash avoidance, road safety, and motor vehicle regulation for Transport Canada. I created and introduced a new printing medium and greeting card line to Michael Chordick, the creative director of Hallmark Cards Canada, to mention a few. At the age of 23, After many difficult roads and paths, I received a tennis scholarship to attend university in North Carolina. During this time period, I managed my symptoms somehow, and in heightened states, mania, could recall pages and pages of text almost verbatim. During my low periods, depression was very consuming. I suffered in silence and pulled back from any social activity or outings that were taking place on campus. Despite the great range of emotions I felt throughout my 4 years of study, I graduated in 1993 at the age of 26, receiving my Bachelor of Science and the Athletic Director's Academic Achievement Award. I returned home to Canada and quickly found my rhythm in teaching tennis to children, teens, and adults. My symptoms during this time period were still present, but were not consuming my daily routine as I was still able to function. In 2 years, I had saved a small fortune working 9 hours a day, 7 days a week. I soon partnered with a friend and opened a restaurant nightclub in 1995. Success was short-lived as my mania led me down a very generous path. I began giving large sums of money away to strangers, churches, and charities. I had to declare bankruptcy soon thereafter. Despite this position in life, I felt invincible and alive. During this time, I met Nicole, and we began dating and soon moved in together. 6 months into our relationship, we discovered we were going to have a child. Our son Christian was born on September 12, 1996, and it was the happiest moment of my life. During the days, I worked as a tennis director, and my evenings were spent with my son, playing, reading, and laughing. We managed to save enough money in 2 years to purchase a new home in a good neighborhood. Family and fatherhood completely fulfilled my being, and the next 2 years were blissful. Sadly, however, this did not last. Nicole left. I did not understand at the time, but learned in later years that my racing thoughts, paranoia, and extreme mood swings took their toll on her and our relationship. We soon entered family court in 1998, and the 2 years that followed were a living hell as we fought over custody of our son. The 2-year conflict had a grave impact on my physical and mental health, and I collapsed one day while sitting in my living room. The doctor diagnosed me with a severe emotional illness and prescribed heavy doses of antipsychotics. For the first time in my life, my secret was out for everyone to see. I was alone, afraid, and devastated. I had no choice in the matter and had to sign over custody of our son to Nicole, learning from my attorney that no judge would settle on a joint arrangement under the circumstances. Weekend visits were all that was granted, and that's how it usually goes. Christian was 4 years old at the time and could not understand why he could only see his father on weekends. Not being able to see my son, the love of my life, on a daily basis was devastating and heart-wrenching. And this led to a major episode in 2003, but I will not go into the details concerning that. Excuse me for 1 second. With good fortune, I was connected to a wonderful doctor here at Ontario Shores. The doctor's kind words helped me navigate through the times of delusion, confusion, and pain. Addressing the trauma, some events that I have shared with you, some events that I haven't. Addressing the trauma of past events with my healthcare providers was paramount in my recovery. The salutary benefits accruing from family and compassionate healthcare providers are indispensable and cannot be overstated enough if the patient is to find him or herself headed in a positive direction. Over the past 9 years, and with the support of wonderful doctors, nurses, and therapeutic recreation staff, I have made tremendous steps in my recovery. In the last 9 years, I began teaching tennis again. I entered family court again in 2006 and was granted joint legal and physical custody of my son Christian. I've lost 30 pounds and have become physically fit, for the most part, despite medication side effects, which led to dramatic weight gain. I unfortunately experienced discrimination in public and in a previous job because of my mental health history, but I'm proud to say that I've won 2 Ontario human rights cases. As of October 31st, 2011, I've attained a position here at Ontario Shores as a peer support specialist. Now, depending on which doctor you speak with, the name for my diagnosis has been varied. Paranoid schizophrenia, schizoaffective disorder, and bipolar have all been used. My diagnosis, however, does not define me. This story is completed, my education continues. Education can be defined as the act or process of imparting or acquiring knowledge. The origin of the word education is from the Latin educare, which means to lead out. In today's changing world, education can lead you out of the morass and stagnation and employment and more. But hasn't that always been the case? Without an education, you're regarded as uneducated. And that category sounds like an insult. So in plain terms, an education is crucial and it involves the acquiring of knowledge, skill, and competence, not to mention the personal confidence and self-esteem that are its benefits, whether in the workplace or in a social setting. Having an education can enable you to better navigate your course in this life. Otherwise, you become directionless. An education is not only a rudder, a stabilizer, it will transform you into something who has something to offer to others or to the community in general. It'll give you a secure sense of belonging, which is essential for peace of mind, knowing that you are contributing to the welfare and good of society. I can't emphasize this aspect enough. Now more than ever before, with science and technology an integral part of our lives, the global marketplace is highly volatile. We are all running a race, but those with an education have an advantage. They're already warmed up to go the distance. To find a job, to have a job, to keep a job is above all a reason to move forward. In other words, gainful employment helps to combat a mundane existence. Finding employment can be frustrating at times. First step is to get your foot in the door. Be curious and show interest in the kind of work you're pursuing. It might not be the line of work you want to spend the rest of your life doing, but at least you have a job, which will help you meet people, establish contacts, and explore possibilities. These circumstances can lead to the desired goals you have in mind. Employment inspires self-confidence and makes you feel good about life and about yourself, whether you work with a computer or at manual labor or with your imagination. The vital thing is to strive for a job that you enjoy doing. Once you find it, that is fulfillment of the highest order. If you have any doubts about this, consider the person who works at a job he or she hates doing, but has to do that hateful job just to survive. Be certain about your qualifications. Think very seriously about the kind of job you want, and then go after it with your heart and soul. You might surprise yourself by exceeding your own expectations. It must be remembered that there are no easy shortcuts to that process or that condition. The only prerequisite for making hope become a reality is to instill confidence in those who hope to improve their present situation. Trust is a two-way street, and compassion for those struggling to better their lives must be a primary objective. Attendant to this is the working method of getting patients connected to supports in our hospital and in the community through education and eventual employment. What these objectives ultimately produce is a positive attitude towards others, a give-and-take atmosphere of goodwill. We all like to be complimented for work that is done well. It's inherent in our nature. Just as dialogue is a search for truth, providing someone with the chance, with the hope of doing well is an accomplishment that dignifies both student and teacher, both patient and healthcare provider. Regardless of place or position, we are all the same. As I stated earlier, trust is a two-way street. If there's nothing so practical as a good theory, then put that good theory to practice. It will yield good results. The end result will prove the equation. Education plus employment, nurtured by an interim of compassion, love, and encouragement, equal the subsequent transformation of patients and their successful transition back to their communities. This is what the human spirit is all about, the chance to fit in, to contribute the skills he or she has learned along the way in order to make him or herself an enlightened individual in society. And though we are neither totally victims of systems nor totally captains of our own souls, we will have earned our place in the sun. Thank you.
Thank you, James, for sharing your story. We now have an opportunity for questions, and I recognize that we're a little bit behind schedule. So does anyone have any questions for the panel? If you could just state your name and the question, and if you have a question for a specific panel member. Yes, Lindsay. Where's the microphone?
Thank you. I actually have a question for Jennifer, and it's more of a specific ODSP question because you mentioned that ODSP takes half cuts half of their payment. So I just wanted to clarify, because I haven't really worked in the employment sector for a while. That's what I did before I did social work. But it used to be that you would get your full ODSP check, and then ODSP would take half your earnings, and then you would get $100 employment top-up. Is that still the way it is?
Yes, so ODSP will take 50% off of the net amount and provide the $100 benefit.
Right. So if
at the end of the month.
so if someone made $500 a week, they would still get their $1,050 plus $250 plus $100, right? Okay. Thank you.
Yeah.
And for those of you that don't know, there's also other incentives to employment supports as well. So there is startup benefits to allow for clients. For now, that's right. There are going to be, that's right. There are going to be changes. Thank you, Lindsay. Any other questions for the panel? Yeah, at the back, and then I see you up at the front.
I just wanted to more make a comment saying thank you so much, because you guys are pretty inspiring, because I definitely suffer with mental health and I have 3 children, and I actually recently just left an abusive relationship, but I let it get to a point so far because I was at risk of losing my children, or else it was, so I stayed in the relationship till somebody finally saw, look, wait, there's something wrong with this person. It's not just her mental health. And I've been very stigmatized and told not to work, and I've been told, you know what I mean, that like I've been told, you know, like it's not happening and you have too much on your plate. But you're right, it's something that we all, I think, want, and to have that fulfillment of being able to say, yes, I can work, or yes, I finally finished my education. Like, that's something I'm still struggling with, and I think my mental health illness has been a part of it, but do I think I can't do it? I think I can. It's just hard when you get other people around you that are, you know, bringing out the, you know, negative remarks and letting that get to you sometimes, because it's definitely, I think they have much as right as anybody else. I think you're right, half the time it's hidden under the table. I've had to explain before in certain circumstances that yes, my mental health might stand out, but you guys are all drinking under the table to cover it up. Like, not to be like rude or anything, but you know what I mean? Like, I have professional social workers, you know, that I deal with, and other people in my life. I have like 16 agencies, and you know what I mean? That's something that I try to remind them, is that I'm sorry mine stands out and I'm being open and honest about mine, but I really believe that, you know, there's so much more out there that is hidden, and I appreciate you guys coming out to share with us today and giving us, some of us, some hope that haven't necessarily got a chance to complete their education yet, whether they're looking after their families or whether they're suffering from mental health. So thank you.
Thank you for sharing.
If I could respond, you're obviously doing well at parenting, because your baby's words or sounds are just so beautiful. So you're doing really well. No, they're beautiful sounds. They're very nice. And also, if I could suggest, find a peer group. You won't get those negative things, and maybe you'll find people who are doing exactly what you're doing. You'll find people that will have confidence in you. So, you know, go online, find a local peer support group, and get involved. I think we find that really helpful. But you know what? You're an adult. Make your own decisions, right? It sounds to me like you could really benefit from a peer group. Thanks for your comments. Thanks.
And there was a gentleman over here that had a question. Sorry.
I have a question for Diana. Diana, I see that you've observed all of our unofficial smoking areas here. I just want to be clear, are there actually designated smoking areas at CAMH?
There is for now. There are, and one of the reasons that they are, we have 2 pieces of land on the property that we inherited from the city. Well, actually, one piece we gave to the city of Toronto. The other existing park was loaned to CAMH. So both those spaces are places where people can go to smoke for now. CAMH is now talking about going tobacco-free, which is a next step in the process, and one that makes me really worried. But maybe there'll be more employment opportunities if that happens.
So, more of those ambassadors,
that's right? That's right.
I personally hate smoking, I don't smoke, but I think that the non-smoking policy is a big problem.
It is,
It's a big
yeah.
problem, and it masks other certain activities.
What certainly the advice that the Clean Air Ambassadors gave to us as they were doing and speaking with smokers every day was that when you're trying to reduce your smoking, a really important thing that will help you with that is activity, especially activity involving your hands. We have very little programming at CAMH, and on the weekends, zilch. And so people get up, they get their coffee, and it's a cigarette after cigarette after cigarette. So even though we have smoking cessation programs at CAMH, I think there needs to be an acknowledgement. 25 years ago, you checked yourself into hospital, you were given tobacco and encouraged to smoke, right? So I think we need to really look at beyond these smoking cessation tools, which are controversial as to their effectiveness. We need to give people other activities so that's not all they look forward to. Thanks.
I'm going to bring this session to a close, but I'm sure our speakers will stay for the break, so if you have more questions. Aaron, thank you so much for your wonderful moderation of this panel. James, Jennifer, and Diana, you have truly given us more insight. And in the earlier presentation, we talked about hope. What I heard in this presentation was inspiration. And we certainly know that from a determinants of health perspective, employment and education are absolutely fundamental. Thank you for bringing that message to us so eloquently tonight. We now have a 15-minute break. I will ask you to return promptly at 7 p.m. If you go across the hall, you will find refreshments.
Oh, I was just asking where you'd like that.
Oh, perfect. No, yeah, I'll take it.
You did great. I have a story, so I stayed specifically. Oh, thank you very much. You were very compelling. By the way, yesterday morning, I was going to board engagement. King, CEO of Cambridge, was sitting beside me. He said, Dr. Imperial was very good. Thank you. Did we clone you actually? Thank you very much, Diane.
She just wants to take photos.
Oh, okay. Oh, so we're going to move out of the way. Yeah.
And I will get better.
Oh, he's just taking a photo.
I'm actually going to check. Hi, how are you, Barbara?
That's one heck of a light. That's a big light.
Yeah, it is, isn't it?
I don't want to see it. I hate my pictures.
I think you like this one.
No, I won't. Okay.
Okay?
Okay.
You want to see it?
Wow, that's a huge thing. Okay, you promise? Oh, that's nice. Good.
Thank you.
It wasn't bad at all. Hi.
I saw that. I know. It started with two. That looks like I'm like, well, sorry about that. You know.
James, can I grab a picture of you? Just sit there.
Where do you want me to?
Just yeah, just sit, and I'm just gonna grab a picture.
It's not bad. Like the nerves are there. It's just I get choked up sometimes. Certain parts. It's just it's a new audience, and it's the first time speaking at Ontario Shores in the lecture theater.
Sheila was very much looking forward to it. She doesn't have that much, so
She shared that.
yeah, yeah, that's great. And so inspirational. Yeah.
That means a lot when I heard it. So yeah.
I said you when she came to me.
She said, "Who do you report to?"
Anyway, afterwards, the ladies was a great job.
Are you staying afterwards?
I'm staying.
Yeah, myself as well.
Okay. When you start, they teach me.
Actually, you know what? I'll get you.
Oh, you're getting photos.
Yeah.
My hair.
Yeah.
Oh, do you want the?
You're in good company, James. I wouldn't be making hair comments because you're both pretty good.
Oh, may I do this? Can you give me some real feedback? Did it come across nervous and rushed, or did it come across okay?
Yeah, it came back okay. Yeah, that's great. You did a good job.
I'll get there, John. I'll get there. What would you like me to do?
Yeah, you can just look at you can look at me.
Smile or no?
What's that?
Should I smile or?
Sure, why not? Perfect. I'll get you just a you can smile.
That's gonna crack me up.
What's that?
I'm not a fan of the photo. May I see? I like that.
Like that?
Yeah, I like that. And I don't like my photos.
All right.
Thank you very much.
Good.
James, wonderful speech.
Oh, thank you very much.
Very inspiring. You did great. Yeah, it was very,
Thank you very much. It's just through the wonderful support that I.
You know what? You did a fantastic job.
Is there food at
There is.
Yes,
there is. You can't get back in that way. No, I won't.
Presentation here somewhere.
Like when you're on your plate?
Yeah, just give it a second here.
Did you want to? Yeah, just. Okay.
We're right here. There she is. Oh, please sit your ass. Anybody? I don't know. I think it was last week. Yes. Let's at least give it a nice clean table. We just use the. Yeah. Yeah, yeah. Yeah, because it'll be on the computers, right?
I'm gonna go first, I'll share. Well, no, this is I'm going.
Sorry, I just took your minutes. Oh, yeah, move. Sorry. How much do you concentrate on? Maybe we'll give it a. Yeah, I got it.
Change put it through its paces.
Does Lindsay want to get hooked up? Does she want it? She's
They're going to be coming to the
Can I just
podium.
use the mic there? That's
Yeah,
gonna be fine.
if you stay there, if you move at all, then you need this.
I'll try not to move.
Yeah? Okay. Just turn this on.
Safe behind this podium anyway. Oh, should I sit?
Yeah, I'll just Sorry, I just want to make sure I don't get hooked up. Okay, tell me when. Welcome back, everyone. We're just going to get started, being mindful of the time. My name is Sanaz Riahi. I'm the Director of Professional Practice here at Ontario Shores. And I'll be your moderator for today for our panel discussion on role of housing and successful transitioning to the community. And it's my pleasure to introduce our first presenter, Lindsay Rule. She's a social worker in our outpatient department here at Ontario Shores, and among many of her key activities, she chairs the Housing Committee at Ontario Shores, where she works with other social workers to advocate for improved housing and access and quality. So please help me welcome Lindsay.
Thank you. I'll start by saying when I was asked to do this chat and I heard that there was about 3 or 4 people that had signed up for tonight, I was pretty relaxed. And then when I saw the email today that said 72 people might be attending, I had a little bit of anxiety. But after hearing the inspirational stories from our previous presenters, I will not let my anxiety get in the way of my performance tonight. So I'll do my best anyhow. So by end of the presentation today, we hope that you'll learn a little bit about how housing impacts mental health and how mental health impacts housing. We'll give you a little bit of an overview of the types of housing that we have access to here in Durham region. And we'll also discuss a recent case study of a successful community transition from a patient here at Ontario Shores. I'll also review some recent research and initiatives that are currently occurring in Canada and across the rest of the world in terms of what works in terms of keeping people housed who have serious and persistent mental illnesses. And we'll also talk a little bit about how we're working to advocate to improve services locally. And we'll end on a little bit of a discussion on how we can help and maybe get some feedback from the audience. So there's several complex interactions between housing and mental health. Some individuals develop mental illness and become homeless due to lack of sufficient income, and others become homeless due to lack of affordable housing and develop mental illnesses due to the stress and conditions of life on the street. So for example, someone may lose their job, become unemployed, ultimately not be able to pay rent, and lose their housing. This person then becomes very scared, isolated, and alone. They may find in the process of that they lose their family and become more and more depressed, ultimately leading them to a state of severe mental illness and becoming hospitalized. Then not having any income would lead them to become homeless. On the other end, someone may become mentally ill, not be able to work due to some of the significant symptoms they may have, be required to enter into a social assistance program where they don't have enough funds to be able to maintain themselves in the community. So just to give you an idea of the relationship between homelessness and mental illness, in Toronto alone, who are homeless for the first time, 67% have a lifetime history of mental illness, and 68% have a lifetime history of substance use and dependence. A lack of housing has major implications for people with serious mental illness, as well as society as a whole. Homelessness alone is stressful, isolating, and dangerous, but when combined with a serious mental illness, those symptoms become worsened. How might I'm just going to put this out to the audience just to see what you might think about this. How might being homeless and mentally ill affect society as a whole? What are the problems that might come out of that? Crime? Mm-hmm. Maybe susceptibility to illness, right? If you're out in the cold. Susceptibility to violence. Yeah. Susceptibility to getting involved in other forms of illegal activity, such as substance abuse, that may also impact health. So homelessness and mental health have a humongous impact on society as a whole and cost the government a lot of money. So it kind of makes you wonder why something hasn't been done about this as of yet. Individuals with serious and persistent mental illnesses frequently identify income and housing as the most important factor in achieving and maintaining their health. It seems obvious. Housing is a stabilizing force in everyday life. It forms the foundation on which a person can establish a daily routine and begin to address other life issues. Due to low incomes, stigma, and difficulties in daily functioning inherent in serious mental illness, fluctuations in symptoms, people with mental illness generally cannot compete for market rent housing or gain entry into scarce, social, or supported housing units. Sadly, many live in substandard accommodations that are physically inadequate, crowded, noisy, and located in undesirable neighborhoods. With the change of long-term psychiatric care in an institutional setting to the community, the importance of stable, affordable, and adequate housing to meet the needs of individuals with severe illnesses has grown. And with that, you might hope that housing access has grown. But we're not quite there yet. So as a social worker who might be coordinating a discharge plan for a client, knowing that housing is a key determinant in maintaining their functioning, what are some things that we want to make sure are in place? We want to make sure they have the finances to afford the housing. And we'll get into a little bit of that as we go along. We want to make sure that the housing program is appropriate, affordable, and accessible to meet the client's needs. We want to make sure it's accessible for the community supports that they may require. And we also want to be sure that they have access to healthy foods. Now, Krista's going to go into more specific types of housing that we do have available here in Durham and that we're able to utilize. And then we'll talk a little bit more about how we act creatively to utilize those housing services given the limitations that we're confronted with. Take it away, Krista.
I'll introduce myself. Okay. It's okay. I'm Krista. I'm a social worker here. I work on the psychiatric rehabilitation unit. And I'm going to look at the types of housing that are available in the Durham region that we often use when people are being discharged into the community. And as social workers, we're kind of the main connection between in the process of people being discharged. So as you can see, these are some of the resources available, and I'll go into each of them. So obviously, market rent apartments are apartments that are available at a market value. Now, the average cost of a one-bedroom market rent apartment in the Durham region is between $730 and $900. And as you go further west, obviously, the rent will increase significantly. Now, if a person is receiving Ontario Disability Support Plan funds, market rent can be super expensive as a single person receives a maximum benefit of $1,050. So you can see if an apartment costs $900, they're only left with like $150 for the month. So sometimes that can be out of reach. And in fact, if a person isn't receiving ODSP and say is on Ontario Works, they absolutely cannot afford an apartment because they get less than $600. So they would have to get like a room in a rooming house. Another type of housing would be subsidized housing, and this is often known as rent geared to income assistance. People who are eligible for this assistance pay a reduced rent, and that is approximately 30% of their total gross household income, and that is seen as an affordable amount. However, the wait list for rent geared to income housing can be several years. And single people and couples who are under the age of 65 have the longest wait lists. And these are often the people that I work with, at least on my unit. And at the end, these are just some statistics. At the end of 2011, there were 4,315 low-income households active on the rent geared to income waiting list in the Durham region alone. And the increasing demand for this limited supply of affordable housing units has increased by 20% since 2006. So the availability remains, or the number of units remains the same, but the availability, or the amount of people who need that housing has increased. And for more information, you can't really see it, but there's a website down there. So I guess you can see that on the printouts. Now, supportive housing is something that we often use when discharging people back to the community. And this is when housing and supports are linked. Generally, staff will work in supportive homes to provide support to the residents there. The level of support varies depending on the needs of the people living in the home. Usually, this type of housing is offered in a group home setting, which can be problematic because not everybody is able to live with other people, or they might have to share a room. However, sometimes this kind of housing can include low support, self-contained apartments, but there's very few of those. Oh, sorry. Sorry, I can't see the bottom. Okay, so examples of this type of housing in the Durham region would be Durham Mental Health Services and also Canadian Mental Health Association.
Code White, FARU, Building 8, Level 1. Code White, FARU, Building 8, Level 1.
And Durham Mental Health Services and CMHA, they're both rent geared to income. They're funded through the government, and they're regulated through the Durham Domiciliary Hostel Standards. Now, Durham Mental Health Services provides individuals with the ability to progress through their housing program. It normally starts out at McKay House, which is high support, and then people, as they gain skills, they can progress through to the more independent units where staff aren't there all the time. CMHA is similar. You're assigned a case manager, and they also have group living and also single apartments. However, the wait list for these services is also quite lengthy, probably about a year. So it's often not somewhere where people go right away when they're discharged from hospital. They often have to go on a wait list and then go somewhere else and then go to this housing. So it's not really an ideal situation. So there are also private boarding homes, and these are homes that are owned and run privately by individuals that operate to support individuals with mental health concerns. These boarding homes vary considerably. They're not regulated in the same way that Durham Mental Health Services or CMHA are regulated. The only regulations that they go by are municipal bylaws in terms of like the actual house and the safety of the house. The level of support also varies. Sometimes meals are provided, sometimes they're not provided, sometimes there's staff there all the time. So that varies also. And a lot of the time when people are discharged from hospital, they'll go to a private boarding home while they're waiting for a subsidized spot to become available. Okay, and another type of housing that we also use would be the Homes for Special Care program. This program was established in 1964. And it was to provide long-term and permanent residential care to individuals discharged from psychiatric hospitals who continue to require supervision and assistance with activities of daily living. Now, this program encourages community living by offering a housing alternative to institutional care. Homes for special care are funded and monitored through the Ministry of Health and Long-Term Care. Ontario Shores oversees several homes for special care, and the ones that Ontario Shores oversees are located in Durham region and also in York region. In these homes, people are provided with 24-hour support. They're provided with their meals, and they're also assigned, each home is assigned a psychiatrist and a homes for special care clinician, which is a nurse. So this person can come out to the home and give the person their injection if that's what they need, or provide other types of support as well, like getting people to appointments and so forth. So this type of housing is quite high level of support is offered. And sometimes, unfortunately, people are discharged to shelters.
Code White, FARU, Building 8, Level 1. Code White, FARU, Building 8, Level 1.
Now we try to stay clear of discharging people to shelters because, it's a temporary and short-term solution. It doesn't offer much stability to people. The circumstances in shelters aren't always the greatest. But two examples that we do use sometimes are Cornerstone, which is for men, and Muslim Welfare Home, which is for women. The only case when we would probably use a shelter is someone's wanting to leave hospital right away and there's nowhere else for them to go. Sometimes the person will be discharged and they'll go to a shelter. Okay, so now I'll talk about a housing success story, and we'll call her Jane. Now, over the years, Jane has been diagnosed with several different disorders, as many people are when they're in the system. She has been diagnosed with post-traumatic stress disorder, schizoaffective disorder, and also borderline personality disorder. She's also had many psychiatric hospitalizations over 30 years. Her two most recent admissions being quite lengthy, months each in length, and also in quick succession to one another. She also has a history of sexual and physical abuse. Jane was last admitted to hospital following a period of instability in the community, wherein she stated that she was feeling paranoid and also having suicidal thoughts. Her family reported that she began becoming unwell almost immediately after her last discharge. Her family also reported feeling burnt out. But while in hospital, Jane's symptoms did improve. She said that she was still experiencing auditory hallucinations, but that the voices she was hearing were not saying bad things to her. And she also stated that while she still felt anxious and depressed at times, the symptoms had improved and they were more manageable. So in planning for Jane's discharge, her partner stated that he didn't feel that he could have her back in their family home because he didn't think he could provide her with the support she had needed, considering the last time she went back to hospital quite quickly. So she agreed to look into supportive housing, and she also agreed for a Homes for Special Care referral to be completed, so that's what we did. There were two openings available, so Jane went to see two different homes. She went with her inpatient social worker and also her partner went with her. She ultimately decided on a home that was quite close to where her partner lived, which worked out well so that he could continue to visit with her frequently and she could remain in contact with her family. So Jane was discharged and she went to this home. Being that it was an HSC home, she was continued to be associated with this hospital and was assigned a psychiatrist and also an HSC clinician. She has now remained out of hospital for over a year, which is great, and reports indicated that while she continues to struggle with her mental health concerns, she is doing well in the home. She attends social club twice a week, helps out around the home doing chores, and also continues to spend time with her partner and her mother. So she's doing quite well, and it seems in this case, at least, that housing kind of was a stabilizing force. Once she had the housing, that was suitable for her needs and the supports in place, she's so far staying out of hospital for much longer than on previous occasions. Oh, sorry, I stayed on the same slide. Okay, now Lindsay is going to finish up our presentation talking about a new housing first philosophy.
Thank you, Krista, and thank you for doing such a great job in reintegrating that woman into the community. It's a lot of work to, engage individuals, especially to embark in big changes like leaving your family home. So it's commendable that you were able to do that with her. So again, since we're shifting into a little more positive note on the topic of mental health and housing, I'm going to just draw our attention to some of the newer initiatives on housing in the mental health system. And this is actually more of a paradigm shift in terms of how to address homelessness in people who are faced with severe and persistent mental illnesses. So this isn't all happening yet, but there's lots and lots of research that's going on throughout Canada, through the Mental Health Commission of Canada, that's looking at how a philosophy known as the Housing First Initiative might be more effective than the traditional ways that we've kind of worked through individuals through different phases of housing. So traditionally, when institutionalization changed the community, as I just said, clients were expected to pass through stages and types of accommodation. So similar to the way that CMHA and Durham Mental Health Services work, which is a successful model, but it has barriers for who can get in there and who can't. So there's no substance use allowed in the home. There's certain rules and boundaries in terms of when they can and can't leave. And, there's a lot of limitations, and often an individual may be denied entry into a certain home based on certain symptoms or certain behaviors or certain legal involvement, right? So there's a lot of barriers to getting into these homes. So while they operate very well, it doesn't get people housed quickly, right? So the idea of housing first is that safe and comfortable place to live is an essential first step to coping with mental illness, and that giving people the support they need in their communities will reduce the burden on shelters, hospitals, and the criminal justice system. So why have barriers to enter a housing program when that just causes an influx of people in all the other systems, right? So the Housing First model rejects the logic of housing readiness and instead promotes the position that stable housing is, for many people, a precondition to participating successful in psychiatric treatment and dealing with addiction. So housing first, treatment second. So some of the recent research on housing first initiatives. There's an emerging recognition of the primacy of housing for recovery and health maintenance of persons with mental illness. A review in 2007 by Dunn and Kyle investigated meta-analysis actually of almost every study that looked at housing as an intervention on mental health. Their study, there was multiple problems with many of the studies that they reviewed, but the ultimate results indicated that after housing placement, there were almost always positive changes in mental status and improved mental well-being. Even more notable was where housing was put in place when the housing was accommodating to that person's needs, in that they had a voice in how they could do things or where they could sleep or what, if they could have a private room or not. Those had major implications on the success of them retaining their housing. So this is, again, a review of studies. I have this in the reference section. We didn't offer it in your folder because it's quite lengthy, but if you'd like to look up the study, it's quite interesting, and it's available on the Wellesley Institute website as well. So even more hot off the press news is that on September 21st, a recent media release from the Mental Health Commission of Canada revealed that Housing First improves the lives of those homeless who have mental illness. So that's huge. It's actually effective. Housing First makes better use of public dollars, especially those who are high service users. Housing First can be implemented throughout Canada. I wanted to emphasize that. A cross-ministry approach that combines health, housing, and social services with non-profit private sector partners is required to solve chronic homelessness. Solving chronic homelessness can create dramatic improvements, and I can't see the bottom of my slide. Well, we know what it can cause, dramatic improvements in our society as a whole. So I'll just move on. So that's exciting news. And there's actually a really interesting article in your handouts there that was in the Globe and Mail just the other week, and Barb drew it to my attention. It fit in perfectly with the research that I was presenting today. And it's from a consumer's perspective who was in the study that's currently being done. I think this is being implemented in Calgary. And it talks about her personal experience in that study and how it's had a significant impact on her mental health. Okay, so what are we doing to improve the situation locally? This is happening across Canada, but we haven't quite got the funding to do the research here in Durham region, nor do we have the funding to, start just throwing people into apartments and hoping that things will go okay. So one committee that I sit on, and so does Krista from time to time, is the Durham Advisory Committee on Homelessness, where local community agencies all gather around one large table to discuss issues of homelessness that affect all areas of disability, all areas of poverty, all areas of sex, race, and every other factor. So we have people from the AIDS Committee of Durham Region, Children's Aid Society, the Social Housing Network, and the list goes on. And we discuss about how homelessness affects all of these populations and review the funding possibilities that are available to different organizations, to different community groups, and work to improve access to housing options and reducing the impact of homelessness on our community. In our committee alone, we talk more about how to improve the housing that exists in our community. So because we're often relying on private boarding homes that aren't regulated, we have to act as the regulators in our advocacy roles. So sometimes that means bringing a home operator in, sitting them down with our housing committee, and just having a discussion about how they're operating their group home. We might review how they could make things better. We might help them to understand a little bit more about, the economic hardship that our clients are faced with so that they can be more sensitive to how much they're paying. We might discuss education on nutritional requirements, anything that can make the quality of lives of our clients living in these homes better. Sometimes it might mean you're visiting a home and you go to open the door and the handle's broken. So you say, we're really interested in this home, but we want to just make sure there's a door handle on the door. So as long as that's in place, then we might consider taking this client into this home. So those are some of the things we do as a committee to improve the quality of the homes that we have access to here in Durham. As well, we're of course trying to keep in mind all of the policymakers that are out there working on new initiatives to improve access to affordable and supported housing within the context of the mentally ill community, or the community who are affected by mental illness. There's probably a lot more I want to say about this, but I'm going to move on. Ultimately, the message is housing is a human right. International law states that Canada must work towards making sure everyone has access to adequate and affordable housing, but some people, based on factors such as race, ancestry, disability, sex, family status, and social and economical status, do not receive housing rights they are entitled to. When multiple factors intersect, the disadvantages increase and people are at greater risk of discrimination, poverty, and even homelessness. Now we'll have a little bit of a question, comments, and discussion period.
Thank you, Lindsay and Krista. Do we have any questions?
Thank you very much for the presentation. I'd like to make a comment, perhaps a little bit of history and context. Excuse me, the Housing First movement is actually about 30 years old. There was a psychologist in Harlem who is viewed as the kind of the guy who got things going. And the Mental Health Commission actually consulted with this guy. But I want to offer a perspective. It's interesting to me how certain things that are around for a long time finally get traction. But I believe the Mental Health Commission did not need to do what it did for that to happen. There are a number of respected researchers in Canada who refuse to participate in the study because it's like asking, is it good to eat? Is it good to go to the bathroom? Yes, having housing is a good thing. And the Mental Health Commission's study design was actually set up so that if someone dropped out of the study, they got to keep their housing. And they had to set it up that way because they already knew it was too good a good to withdraw. So I think it's important that we provide some context. This was a political exercise that was a way of saying we somehow have new data, but we don't have new data. We've proved what was obvious. And I wish the $110 million had been spent on direct housing in programs that we already know work.
Thank you. And I completely agree with your comments. And if I had a series of presentations, I might go into the history of where all these came from. But unfortunately, tonight I had to keep it very brief. So I'm very aware that there was studies going way back in the U.S. and all over the world that used this philosophy, and it worked, right? And we're just now only some parts of Canada and some policymakers adopting this philosophy, right? So it is a major political issue, and I think you make a great point. So thanks for sharing.
Thank you. Are there any other questions or comments?
This is Mohammed. I'm coming from Scarborough, and I work with Kota Health. We work with mental health and justice housing program, long-term housing program. And my colleague Salah is here. I'd like to echo with your the presentation today. It's a great presentation, and on the front line, we are seeing every day that how housing is impacting people's life, and they really helping them to improve their quality of life a lot. And most of our clients is involved with justice system. They came from bail or from the jail. They came out, and some of them they don't need to visit hospital in last 3, 4, or 5 years, which is a great achievement of the program. And we have 120 units in Scarborough and North York. It is a successful program. Every year we're seeing that how grateful the people are who are living with us like a family. Thank you very much.
Thank you.
Any other questions or comments before we wrap up? Okay, well, thank you so much for your great presentation. We appreciate it. Thank you.
Thank you very much, Krista and Lindsay. You have just presented the third of 3 core determinants of health, and that is housing. So you've certainly brought us very helpful information on that. Thank you all again. So it is now my great pleasure to introduce our closing keynote speaker, who is well known to many of us, Dr. Phil Klassen. He brings more than 15 years of psychiatric experience to his role as Vice President of Medical Affairs at Ontario Shores Centre for Mental Health. He works closely with the medical and clinical leadership teams to support the organization's objectives within an evolving mental health care system to ensure a sustainable and comprehensive network of services. And we've certainly seen the powerful evidence of the need for this network. Tonight he's going to talk to us on reflections on research, effectiveness, and outcomes associated with assertive community treatment teams. Please help me welcome Dr. Phil Klassen.
So it's a bit of a daunting task because I was asked to sort of review a little bit of research on this topic. Now, a couple of caveats. First of all, I'm not an ACT psychiatrist. I am a psychiatrist. I'm not an ACT psychiatrist, but I've been involved with administration of ACT, more previously at CAMH than here. What's that?
Do you have a PowerPoint?
Sorry?
PowerPoint?
Yeah, it should be loaded, right? There is a PowerPoint.
Okay, so let me just...
Let's hope it's loaded. Should we hit escape?
No, here. There.
Great. But we're speaking to an audience that is very wide-ranging in terms of their background knowledge. We have everything from Dr. Marr, who is an ACT psychiatrist here with us in the audience, to a charming, maybe 3-month-old or 5-month-old. How many months? Oh, I'm sorry. I didn't get a chance to see the baby. So I have to find a way of appealing to that broad audience on a topic like research, which is a challenge. The other thing about assertive community treatment is that, I mean, as I've learned, that the literature on this intervention is far from cohesive in terms of the outcomes and the effectiveness research. So anything, the other caveat is anything that I might say to you today, I know that you'll be able to find a paper that says the opposite. And interestingly, there's a big sort of European and UK and US and Australia divide in terms of what's being said about outcomes and effectiveness of ACT. So I'll go for a bit of a tour of what I'm thinking about ACT, and we'll have time for questions at the end, and we can see where that takes us. This is what I propose to talk about. A little bit about what is ACT, what we have ACT doing as part of a delivery system, who we're supposed to serve, and a bit about outcomes and effectiveness. So assertive community treatment probably has its origins in the late 1970s or around 1980 with some publications that proposed a very different treatment model. And I still remember very clearly working in the 1980s where the outpatient model for treating people with major mental illness was basically they had to come to the hospital. We focused on giving them medication. And if they didn't come to the hospital and get their medication, they were non-compliant and they were discharged from service. And I think it was recognized that for people with low social capital, who were homeless, who didn't have a lot of funds, a small social network or no social network, that first of all, it's asking a lot to ask the patient or client to fit into that model. And secondly, simply reviewing their symptoms and prescribing medication really didn't address all of the needs that these individuals have. It was certainly recognized that persons with major mental illness had real struggles. Not all of them, but some of them had real struggles fitting into that model and moving forward as much as we'd like. People with serious mental illness like schizophrenia do struggle to engage in treatment at times, and of course getting people to use services is the necessary first step to having those services work. People with schizophrenia or similar major mental illnesses have high rates of medication, non-adherence, which renders them potentially ill and therefore less able to participate. So the feeling was, I think, that we need a model that is both more patient-centered or client-centered, that moves the service delivery to where the patient is, geographically, psychologically, etc., and that provides a real range of services within one team, as opposed to sort of brokering out for service. You're my outpatient. If you need X, we'll send you to that clinic at another place, kind of thing, as opposed to we're going to try to support you entirely from within our organization. So this slide highlights some differences between assertive community treatment and treatment as usual. One caveat here also is that the way that ACT teams are configured is not identical. It's not identical across jurisdictions. It's not identical from country to country. That's not necessarily because of philosophical differences. That may be due to local differences, problems with hiring, problems with retention, shortages of health human resources, those kinds of things. But ACT teams can look different. Typically, ACT teams have smaller caseloads than a standard outpatient clinic. They tend to have low volume caseloads per staff person. They use a team-based approach, as many of you will know. So It's not simply Jill has 10 patients and Jack has 10 patients and they go off and see their patients, but that there is more of a sense of shared or joint or collaborative mission around helping those patients or clients. Skills needed are in-house. Hours are extended, often 24/7 with an on-call person available. That the team meets clients where they live, and the focus is on engaging them and getting them to use service and improving client satisfaction with the service that is used. And oftentimes there's high frequency clinical contact. I remember that when I was at CAMH, the forensic team that I was not working at, but sort of involved with, it was not uncommon that we would have individuals who were seen twice a day, every day. So that's pretty high frequency clinical contact in comparison with treatment as usual. So ACT is a high intensity outpatient service, and it is a service that typically in different configurations offers a variety of different skill sets and a variety of different professions available. It's important to have a prescriber. It involves nursing staff and case management staff and a variety of other individuals, which vary somewhat from team to team. And not uncommonly, the service will have some access to inpatient beds, so there'll be some kind of a memorandum of understanding or a linkage, or the team itself is hospital-based and therefore has access to the hospital beds. Now, you might have heard that we're not running a huge surplus here in the province of Ontario this year, or next year, or the year after that, etc. And so, the cost is relevant, and of course, the cost of this kind of a service is felt to typically be more expensive than standard outpatient care. The model, as I said, places a high value on engagement, and there's only 3 bullet points there, but unfortunately this bottom bar always seems to cut off that bottom bullet point, I guess, for me as it does for you. The expectations are, though, that the clients will be more satisfied, more engaged, that they will be less institutionalized, and that's important for a variety of reasons, obviously, and that they're going to have better, I think it's going to say that they have better outcomes in other ways as well, the piece that none of us can see. It's important not to be institutionalized. That may seem self-evident, but whether you're institutionalized in correctional facilities, which are typically the second largest mental health facility in any given community, or whether you're hospitalized at an institution like this, it often involves a rupturing of connections that you make. It involves a gradual erosion or deconditioning of independent living skills. And I think you have to anticipate that despite the best efforts of an institution, you face the potential for loss of certain things if you have to leave the community and go into an institution. And so that's something that we want to avoid. So then there's a question of, boy, there's really no way of removing this bar from the bottom, eh? That's got to stay there? Okay. So who should be referred to ACT? Most, in simplest terms, people that are referred to ACT are typically people who have high needs and who have been difficult to serve. So people most commonly with serious major mental illnesses. People, and again, I'm not talking just about what happens in Durham or York. I'm sort of reflecting on Canada, the United States, UK, etc. There are people that have high needs that have been difficult to serve, that have spent lots of time in hospital or in institutions, and who are felt to require a high degree of contact for engagement, for service utilization, and to improve outcomes. Most of these clients, as I've said, will have schizophrenia. Statistically, what you see typically is they'll have schizophrenia, delusional disorder, schizoaffective disorder, or bipolar disorder. The psychotic illnesses tend to be the most common conditions that you're going to find. And there was something else under there, and I can't remember what it is. So what are some of the things? So this all sounds great, and ACT is great, and I'm going to tell you what I think. Oh, that helps a little bit. Thank you. I'll have a drink with that too, please. So ACT has been great, and I think that not really having lived through this period of approximately 30 to 40 years that ACT has been grown, I think one of the enduring legacies of ACT is probably that ACT, through both the values of ACT and the operationalization of ACT, really changed the way we think about outpatient care. Again, reflecting on, I worked at a downtown teaching hospital in the 1980s as a resident, and the outpatient model that we offered was very poor indeed on reflection. And I think what ACT sort of said was we have to completely rethink the model, and I think that's great. The struggles, I think, for us clinically recently have been access to ACT now and today. And I think that these struggles have been going on for a while now, and I think you see them in Toronto and you see them here. I'm speaking more locally now, which is that ACT teams tend to fill up. The turnover on ACT teams, partly because their mandate is non-time limited. The turnover tends to be relatively low on many ACT teams, and therefore the challenge is to get the patients that you have in hospital today into an ACT team. And it's the struggle to discharge to ACT that I think is one of the challenges that we're facing right now. Although there is a group in Durham, I know, that are working on really making that better, and I think that I'm very hopeful about that. The other things that have been challenges is that when I say model fidelity, I don't know if you see that there, when you're looking at the research on ACT, again, different teams show varying degrees of fidelity in different countries and different places to the original or to the sort of full-on model. There have been challenges around this. You can't see this really. I can see this. It's the last bullet. Oh yes, you can see it right underneath. ACT teams really are very much aligned with the recovery movement, which says we're here to empower the patient or client. We're here to help them select goals, support those goals, and deliver for them hope and improvement in a variety of domains of their life. But in fact, oftentimes, the part of helping some of these patients involves legal mechanisms of coercion or control, like community treatment orders. In the United States, it's called outpatient civil commitment, or use of detention orders or conditional discharges under the ORB. And this has been a subject of some debate. What's the compatibility like between ACT and recovery and these kinds of legal mechanisms to keep people in treatment? That's not a concern about ACT as much as it is a concern about the intersect of these different kinds of forces. So, outcomes and effectiveness. ACT has been widely studied. It's one of the more studied psychosocial interventions in the history of mental health. As I indicated earlier, the other caveat that I didn't mention is that I'm prepared to be a little bit of an agitator in some of my conclusions, so you're welcome to challenge me. And the other caveat is that I personally think that there are aspects of our health system that are more similar to the European model than to the American model. So I always find that appealing, or to think about that when there appears to be a bit of a continental divide. So there is a bit of a divide. U.S. Research is typically more optimistic about ACT outcomes and whether it delivers on its promise. UK and European studies are a little bit less optimistic. Generally speaking, studies of this kind look at a variety of outcome variables, but what you're really looking at is ACT in comparison with some other intervention, and how much it may improve people's outcomes in certain ways. But then you can imagine that that's not just about ACT and the other intervention in a static way. So it's going to depend on what kind of ACT Is it the kind of ACT that we really want? Does it show good model fidelity, etc.? What's the other intervention? So if the other intervention is poor outpatient care, you should show a bigger difference. And one of the things that has been written, that's been the subject of authorship recently, is that ACT, in a way, has dragged by ACT's promise, has dragged upwards or pulled upwards the quality of outpatient care generally, so that studies now are going to show less of an advantage for ACT than studies would have 10, 20, or 30 years ago, because ACT, in fact, is exerting that kind of a pull on outpatient treatment, saying you can't do it the old way anymore. You have to do it this way. And the other thing to bear in mind is that if we pick the right kinds of people for ACT as clients, seriously mentally ill people, then those people, you know, are people where most models are unlikely to have huge impacts, right? Because a lot of those people are going to have fairly serious or even treatment-resistant kinds of illnesses. Okay. So, you know, there's a host of outcome data, and I've amalgamated some of this. ACT in the U.S. they'll say it's cost-effective. In Europe, they will say it is not cost-effective. I wonder again if we remember that whenever we're comparing two things, the question is what are the two things? Use of hospitals in terms of cost, in terms of who decides it, in terms of what the insurance company will pay and how many days you get and all those kinds of things, I would respectfully submit is quite different in the U.S. than it is in the UK and Canada and European countries with a public payer system. So that may have an impact on looking at hospitalization, because hospitalization is the main. You have to prevent hospitalization for ACT to be cost effective. The people that appear to benefit the most from ACT are those with severe illnesses that have spent a lot of time in hospital previously. A number of reviews have suggested that you are going to save a certain amount of time in hospital through use of ACT. You are going to improve medication adherence. Some studies have suggested that model fidelity is very important. That is to say, if you have all the components of ACT, you're going to get a better outcome. Some studies have suggested that staffing makes a difference, and some have suggested that staffing doesn't make as big difference as the skill set. That is to say, it's less a question of credentials than it is competencies. If you deliver certain competencies to the client, whether that's from an RN, whether that's from a social worker, whether that's from a what have you, peer support, etc., that's going to deliver on the promise of ACT. So, you know, there is a Cochrane review, and these are the results of the Cochrane review. For those of you in the community that are not in the health professions and you haven't heard of a Cochrane review, the Cochrane collaboration is based in the UK, and they do these very large reviews where they collect as much or all of the data that's out there. They crunch the numbers themselves, and they tell us what sort of the global data set suggests. You will gain some things in looking that way, and you will lose some things. When you put a lot of data together, you lose nuances, subtleties, outliers, certain opportunities to learn, and you gain other things. You can look at trends in a more powerful way. So when they compared what we would call ACT to an intermediate kind of service delivery, which they would call low caseload non-ACT, they said that ACT reduced hospitalization, but that what really mattered was, or what really made the difference was in high users of hospital beds, people that had spent roughly more than 100 days in hospital over the preceding 2 years. ACT improved engagement and satisfaction. It improved independent living as opposed to living in sheltered or supported environments. And it improved their global assessment of function, which is a score that sort of tells you how well a person is functioning, both in terms of their activities of daily living and in terms of their symptom burden, like depression, psychotic symptoms. It did not change. ACT did not show an incremental effect on social functioning, on criminal justice contact, on employment or rates of employment, or on mental state scores. And these findings were typically found in comparing ACT with treatment as usual as opposed to low caseload ACT. Now I'm conscious of the time, so I'm going to flip through these. You're welcome to have these slides as far as I'm concerned. I'll flip through these slides fairly quickly. Just to show that even with ACT, engagement remains a problem with persons with serious mental illnesses. So I don't have a laser pointer. I do have a laser pointer. I do have a laser pointer. And this laser pointer, this is Opus is the ACT type arm in this study, and this is the sort of treatment as usual. There was an improvement, but there are still problems with engagement with this group. There may be some issues with sustainability, and I think this is important when we select people for ACT. The sustainability issue, respectfully, I don't think is an ACT issue. I think this is the nature of the kind of people that we're talking about. By which I mean, when you're talking about people with serious deficits with respect to social networks, social capital, skills, education, symptom burden, and so on, even if you give them ACT for 2 years, if you remove the ACT, they could still have problems. That it doesn't necessarily become a self-sustaining process. And so this is a group of people in this case who were followed up for 5 years, and they were taken off ACT during the last part of that. And so the people that had ACT initially, as compared to standard treatment, there were really no great differences at the end of the follow-up. That is to say, the people that had ACT looked like the non-ACT people once you removed the ACT. Now, that's not inconsistent with the model. I mean, the model says that these people should need long-term engagement with ACT. Again, the other hot debate is, does it have to be really ACT, or as we find, pretty good sub-ACT services, do we wind up with results that are fairly similar to ACT? And in the UK, the answer from the UK would be yes. You can wind up with fairly similar results with ACT Light, if I can put it that way. This is a UK study looking at cost effectiveness, and you're going to have to trust me that I've highlighted certain data that are exactly under here. And this data that I've highlighted would say to you, well, you can find it if you want to. There's the publication. This data says that if you look at, I think they had everything except the cost of medication in their equation. If you looked at ACT versus treatment as usual in the UK over 3 years, and you looked at hospitalization and emergency department care and court costs and residential care and everything else, the cost of ACT was £35,000, and the cost of usual care was £30,000. So ACT, but that's not I don't think that was a statistically significant difference. I can't remember. I can't tell. It's covered up. These are the two boxes down here. But that does include hospital care. So in this case, ACT was not less expensive, although, and here again, this is again a European study, just to show you the breakdown that with ACT, the cost is largely outpatient and not much inpatient, and with non-ACT, the total cost is fairly similar, but it's separated out or divided in a very different way. The role of peer support is not entirely clear. This is from the Journal of the American Psychiatric Nursing Association, a review in 2011. It wasn't totally clear whether peer support made a difference in these regards, but you have to bear in mind that you're just adding one more dimension, one very important dimension, but one dimension to a heavily staffed process. And so, in fairness, it would be asking a lot. I mean, the power of peer support would have to be enormous to show a statistically significant difference. It did improve, however, engagement, and engagement is the first step for ACT, so that's important. Other issues in terms of the benefits of ACT as compared to other treatment models. Again, we talked about model fidelity, local costs. I mean, ACT may be fantastically useful where cost effectiveness-wise, where hospitalization is expensive. In developing nations, where the cost of hospitalization is minuscule, is picayune, there is probably, you will never show an advantage to an ACT model. The cost effectiveness comes from preventing institutional costs, which include, and I should tell you there's a literature on forensic ACT. It runs quite parallel to the literature in non-forensic ACT. The main benefits are in reducing the costs of institutional contact. There are ACT studies looking at children and adolescents, fairly well, pretty much in parallel, I think, to what you see in adults, although a little less well studied. Dually diagnosed patients have also been studied with similar results. forensic results are similar. They've looked at ACT for primary substance use disorders, that is to say ACT for let's say alcoholism, alcohol abuse disorder. It does not seem to work as well with that group of individuals as it does in the groups that we've described above. So some of the challenging questions for us, recognizing the huge contribution of ACT, is what level of caseload is the right one? I think historically we had this great divide. There was ACT, which provided this great high-intensity service and fairly crappy outpatient services by comparison. I think we need to think about the gradations. Who should get what? Who should get, full-on, 5 days a week service? Who should get, because, we have to, of course, we have limited resources and we have to think about how to partition those. So I think we probably need more, instead of just sort of dichotomizing it into ACT and non-ACT, I think we need to probably be a little bit more elegant about how we slice the pie. I think it's interesting that the notion that instead of focusing on the professional designations of the staff, to think about their core competencies and who can best deliver the core competencies rather than thinking about their specific credentials. I think given that ACT is supposed to be a long-term investment in seriously skills-deficient, marginalized, and ill individuals, I think we need to make sure that we are vigilant about who goes to ACT and who we ask ACT to take. These days, it's become sometimes almost synonymous that if you have a patient with schizophrenia that's an inpatient and they're a bit of a challenge, they should go to ACT. Maybe that's not right. Maybe we should be really rethinking that, because we have a limited number of ACT places in our community, and it's up to those of us that work in hospitals and that help sort of set direction for inpatient units and other service providers that we say, you know what, let's make sure that we deliver to ACT those people where ACT has the most to deliver to them. And again, if in fact gains are difficult to sustain, then it underscores the need to select the clients carefully. I think I've used approximately, almost exactly, 35 minutes actually. And I think I would have been over time, but for the fact that this bar across the bottom has saved me from approximately 10% of the work that I put into this talk. So maybe I'll leave it there.
Don't go far. No, stay here for questions. So are there any questions from the audience regarding Dr. Klassen's talk? Thank you, Jennifer.
Thank you, Phil.
Hi, John.
For the excellent presentation. I want to echo what you said. The selection matters, right? The people who need it most makes it cost effective.
Yeah.
And I assume you're familiar with the Ontario data, but it's viewed as some of the most robust data in the world. Lindsay George at McMaster. The cost savings to Ontario, when this was done, there were about 50 teams. Now they're about 70, but it was averaging $70 million a year after all variables were controlled, which is why the government went from 50 to 70 teams. So it's saving money in a very crass way, but seemingly more than just hospital admission. They were trying to measure other things as well. The average length of time someone is with an ACT team in Ontario is 5 to 7 years. So part of the problem with getting people out of ACT is not just teams keeping them, but we have no places to send them to. Outpatient services have waiting times of up to 1 to sometimes 3 years, right? The other thing, though, that's of concern that I'll offer as a comment, there's data coming out of the States now that about 70% of people who are viewed as stable, and in ACT terms that usually means 2 years of really minimal service, so they've been stable for quite some time before they're discharged, about 70% are relapsing within about 2 years. And the suspicion is what the person has lost is the developmental scaffolding, in effect, the care or family system that gave them the sense of accomplishment, success, and made it possible to move on and do all the things like get back to work, like to do a whole bunch of stuff.
Are you saying after they've left, after they've been discharged from ACT, there's a relapse rate?
About 70% it's looking like, yeah. Which is why, and you had commented on this, but the notion of a step-down model where we continue to provide our own care and service can be bumped up as needed during crises or the inevitable vicissitudes of life.
Yeah.
So my plug is...
I totally agree. I'm sorry, I don't mean to cut you off. Excellent comments. I mean, John Marr knows a ton of stuff about ACT, and you should ask him after the talk if you want to know more stuff about ACT. But I totally agree with John. I think that the notion of, I mean, it's the same thing with housing. It seems like we have high support housing, but there ain't much. And then, we have a lot of shelters and sort of, very simple group homes. And the more that we can cascade people so that the scaffolding comes off slowly, the cast or the splint or the supports, however you want to frame the analogy, comes off in layers instead of you're in ACT and you're in high support housing and then you're in a shelter and you're going to an outpatient clinic. The more that I think we can think about the gradations, the more likely we are, I think, to be able to sustain, gains instead of, as you say, having them decompensate or deteriorate or not be able to sustain what they've achieved and what ACT has achieved.
Thank you, and I'll offer a quick final comment on peer support, if I may, because this was an eye-opener for me. Yes, helps with engagement. Yes, helps with relationships with some clients, no question. But to me, the greatest benefit was not what I expected. The peer specialist, if they're doing their job well and have the confidence to do it, to call a spade, they are challenging the internalized stigmatization of the team members.
Yeah.
They remove the us-them barrier and make us all better clinicians, and I think that's their greatest contribution.
Yeah, I think that's a fantastic comment. We have lots of experience with James and others here that have just, I think, been such an incredible eye-opening and positive experience for us. And I think you're right. The missing element really is probably going to stay missing because the steps are not simply peer support to client. I think the really powerful step is peer support to the rest of the professional community working with those clients, to the client. And if you're just looking at the client, the client outcome in those kinds of ways, I think we're missing something. I totally agree with you. I think the effect on the rest of the staff, it's a very good insight. It's powerful.
Any other questions or comments? John, you're pointing to someone.
Hi, I'm Kathy McMaster from the Oshawa Community Health Centre. I just wanted to say we're starting to work on a program with Ontario Shores, partnering with some psychiatry every other week. And what a community health center can do is that we do have nurse practitioners and primary care providers, but we also have a therapist positions. We also have social service workers. We also have programming and all kinds of supports from child care through to food supports, etc. So I think we're definitely working within Durham to try and strengthen the partnership and fill in that gap because those are the clients that we're dealing with day to day. So
yeah, are you working with Tarek?
Yes, I am.
Yeah. No, I think
Yeah,
that process shows a lot of promise, and that's sort of what John was just mentioning, that whole notion that we need to kind of try to fill the gaps in a gentle cascade to empowerment and full independence, and that's a part of that process.
For sure, and I know there's some community partners here we have to be in touch with, strengthen some partnerships.
Okay, any last comments, questions? Okay, well, Dr. Klassen, you've ended our evening. Oh, you did? Very good. Sorry, I didn't see that.
Hi. This terrifies me, but I just was going to say that from a patient standpoint, if you don't give up on the person, they won't give up either.
Yeah, I think you're right. These people need our support.
Things have to happen gradually. If whatever the heck you want to call the illness, if something drastic happens, which happens to everybody, but a little bit of gradual, like you're saying, the layers, it's a better chance that, the longer the person's out of in the hospital, then the harder it is to get back. I can't describe it. We get this fog of things being done for you, and picture like the kid in high school that thinks everybody's looking because he's got a zit or whatever it is. That's a really simplified thing, but anyway.
Well, it sounds like you're saying that you've had the personal experience of that kind of sense of loss of personal vigor or energy to go forward that happens to people sometimes when they go through institutional contact or mental health crises, which we know and which we have to work to restore.
Yeah, I mean, it's not just me and my family, it's other people in the family that have it way worse than me, but just gradual steps.
Yeah.
Then you're not going to be starting back at square one. I start back at square one all the time. I'm always looking for a shortcut, and I don't know.
No, I think I agree. I think, that's consistent with Dr. Morrow's comment, John's comment, and the notion that we really need to find a way to make each step as smooth, as almost imperceptible as possible. Now, that's in a perfect world. But, an example is withdrawal from benzodiazepines, or let's say methadone maintenance treatment. We know that if you want somebody to withdraw from these agents, which are addictive, maybe a bad example, in a lasting way, you say, we're going to take you off this medication over 3 years. We're going to drop the dose in such imperceptible increments that you won't even notice your loss of reliance on these agents. And I think that while that may be dramatizing it a bit, that's what works with respect to those kinds of difficulties. And I think that the more we can make that sort of empowerment process feel smooth and almost imperceptible from one step to the next, the better the chance of success.
And more people with success as opposed to fewer.
Yeah, and people also lose hope if we give up too early and somebody goes back to hospital. Of course, that's going to be bad for your sense of hope, for your sense of.
And instead of being in the hospital a month or 2 months or whatever, it may be a year, which has happened in my family, but not to me.
Yeah, I agree. I think it's an excellent comment.
I didn't mean it to be. Thank you.
Okay. Final comments, questions?
Peter, so.
Okay, well, again, Dr. Klassen, I want to thank you so much. I think what you have shown us so eloquently with your knowledge and with your experience and with your compassion is that there are programs. We have some science and research in their effectiveness, which tells us how best to use them. So you've ended our symposium with great hope again. Thank you very much. So we have indeed come to the end of our symposium. Thank you so much, everyone, for attending tonight. I hope that it was helpful to you. I found myself reflecting and listening to our proceedings tonight about our own Ontario Shores tagline, which is discovery, recovery, and hope. And I think we have seen all of that played out in our discussion of the topics that were presented. We've seen tonight real stories, real successes that tell us that we can make a difference. And those of you who spoke who've experienced mental illness, I salute you and thank you for your courage in doing so. So on behalf of Ontario Shores and Healthy Minds Canada and all of our partners, thank you again for being here. Good luck, and we'll see you again next year. And just please leave your evaluations on the table out front, please.
Yes, I just have to save it now.